The baby was born the day after Christmas.
No way.
Yeah.
Oh, how are they?
She's good.
Boy, girl?
Girl, her name's
Was she
Aspen.
early?
No, she was due on Christmas Day,
Oh,
so she was a day late.
where is she?
Thank you. She's
Where is that
sleeping.
sweet baby? Okay, well, you have to
Yeah,
show her to me later.
I will.
Okie dokie. We are going to go through the course overview. My laptop is broken, just a heads up. Okay, got it. With so many people in here, I'm going to keep my chat open, but also my big TV screen is not working, unfortunately, because there's something wrong with our Connectee system. So, excuse me, please do not ever hesitate to interrupt me when you have a question, okay? There are like 52 students in here. Believe me, if you have a question, I can almost guarantee somebody else does. Yes. I did not enable them yet. Okay. Okay, so let's go over our course overview. Okay. Do you guys have Ring Central pulled up in front of you? It would probably be helpful if you do, because well, I don't know. My projector should still work, right? Let's a lot of my students find that it is helpful, like when you're in the classroom, to also have it in front of you, because sometimes this is like, I don't know, it's yucky looking. So, the password is Simmons with a lowercase s, if you want to do that. What? No, you have to like right click it or copy and paste the link. Why put a link if the link's not going to work? Like I don't know. I don't know. I don't know. New book codes are coming. Can you let me in? Yes.
What's the password? Sorry.
Simmons with a lowercase s. New book codes, if you need them, are coming. So please give that 24 to 48 hours for Lippincott. If you need ATI scrubbed, make sure you reach out to Dr. Bowling and let her know. She always has a list going, but you know, we're all human and we make mistakes. So I don't want to have you forgotten and then it's week 3 and you're like, Jess, I didn't do anything on ATI because it hasn't worked this whole time and then you never told me. So please don't do that. That will aggravate me. Just being honest. Okay. Okay, so let's go over our course overview. Oh no, I see. I just have to admit you. You just have to tell me. I can't keep the chat and the participation list open at the same time. Oh, and make sure you guys mute yours, because then it'll be all woo, woo, woo. It'll be good. I did update all of the dates in Lippincott and in here. So all of the dates should be correct in week 1, 2, 3, and 4 of like due dates. no idea. I was just thinking, I was like, how would I do this? Like, I haven't pulled up, and I was thinking, I'll push this to my husband. Everyone to show everybody to. You could be that. Okay, so course overview. In week 1, we are going to cover cell physiology. We're going to go into cardiac. Every system that I cover, and this is just a blanket statement. This is not towards anyone in specifically, but I have noticed that there isn't a strong foundation of anatomy and physiology. So every new content that we're going into, the very first thing we're going to do is cover what it should be, what it looks like, what it should look like, how it should perform. So we are going to cover A and P, and then we're going to get into what do we do when things go wrong. Okay, because you can't understand what to do when things go wrong if you don't know how it works when it goes right. Okay, so we are going to go over cardiovascular system, drugs affecting blood pressure, heart failure meds, antiarrhythmics, anti-angina agents in the first week. Okay, so the first week is first of all, this whole class is very heavy. Okay, there's a lot of assignments. There is a lot of content to cover. And I will absolutely do my best to make sure that everybody is on the same page and understanding the content. So on that first Sunday, which is the 8th, right? Yes, the 8th. So these PrepUs 43, 44, 47, the 1-minute nurses. By the way, the 1-minute nurses, you have to do the quiz and you take notes on the video. You have to upload both the quiz and the notes to get the points, okay? So I don't care if you even take a picture with your phone. Like literally you finish it and it says complete or whatever, like 9 out of 10. I don't even know. But also you can go to like reports in Lippincott and pull up that specific report and you just literally take a picture, upload it to Brightspace. Okay. Do we upload ATI? Yes, you will upload ATI, report and remediation. Okay. So all of these assignments are due on Sunday. The 1-minute nurses, I mean, they're literally 1 minute, like they're 1 minute. The PrepUs, I think those take a little bit longer, but not too much, hopefully. And then obviously we have the ATI RN pharmacology practice test A with remediation, and that is also due on the 8th. Okay. Oh, and by the way, we do not, and this is why I didn't email anybody back about it. We do not have a math module. 2210 Advanced Pharmacology does not have an ATI math module. Okay. We just have regular old math. All right. And we will be doing math in class today at some point to practice for your math exam.
Can I ask a question?
Is it about math?
Yes. Well, kind of. Like just about.
Go ahead. Because I was going to have you wait.
Okay. I can wait if you want me to. It was just about the testing. Like if I have to come to if I pass the first one, do I have to come to the other days in person?
No. If
okay.
you pass the first math exam, you don't have to take the other 2.
Okay. I just was, because normally they did them after our test and I don't have babysitters, so I have to like figure it out. And so I'm like, oh, I needed to figure out like when I could, if I needed babysitters for those other days, and I just wasn't sure. So I can let my mom know.
Yeah. Nope. And the reason that we did this is because students for forever have always been, it's really hard, especially when you don't do well on a test, to go right into a math exam, right? Your brains just like are like, I do not want to do this right now. And we have seen statistically that it is not working well. Okay. So something has to change. And that's why this change has occurred. Okay. It literally just went live in February. This is the very first term that we're ever doing math like this. Yeah. We'll get there. We'll get there. Okay. So, any questions about what is due the first week? And you know what, I might as well because math is the first week. Okay.
I do have a question.
New math testing policy effective February 2026.
Miss Simmons, can you hear me?
Yes, ma'am.
Hi, got a question.
Yeah.
In regards to your lectures, are our notes required to be uploaded?
No, ma'am. I could care less.
Okay. Okay, thank you.
I already have too much on my plate. I don't have, nope. Respectfully, I don't have time. I just don't. About notes. I don't need your notes uploaded. It's not a requirement for my class.
For class.
Yeah.
Oh,
Yeah, no. I don't have time to look through your notes and make sure that you're taking adequate notes. At this point, I would hope that we have established note taking. I hope that's okay with everyone. Okay, so week 1 math requirement. So this is a little bit different because this is covering the math module. Like I said, and I'll say it again, we do not have a math module in this class. Okay, no ATI math module. So this just says ATI math module completion, blah, 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 blah. So what we will be doing is we will be going over math today. I will be doing math with you today to make sure that we are all on the same page on how and what is expected for your math exams. All 3 math exams, 1, 2, and 3, and your worksheets and remediation are all the exact same with different numbers, okay? They are completely 100% the same. So practice makes perfect, and we are going to practice, and we're all going to pass the first time. It's going to be great. It's going to be so good. But no, seriously, I have found specifically in my classes, the first time that I did math as a group with my entire class, our first math exam, I'm not kidding, I had like 30 out of 32 pass on the very first try. And then the next class, it was a little less, there was like 7 that didn't pass, but I did not have any math failures. I had 1 student fail my class because of math it was either October or November. I don't remember what it was. And I vowed that I would never let that happen again because she literally passed the class with like an 80% and she ran out of time. And it was, I'm not kidding, her and I sat in my office and we cried because like, I just couldn't believe that I had to fail a student for math when she passed the class and passed clinically. So I am not in the business of failing my students, and I really don't want to. So hopefully going over math together as a group will negate that. Okay? All right. And then with our math test, the math exam is Thursday at 2:30. Is that the same for every? Yes. So it is after lecture at 2:30 on Thursday. Did everybody see that on their schedules?
Miss
Okay.
Simmons, so I
Well,
live
yeah.
an hour away. Would I be able to leave class a little bit early?
Yes. So what I would suggest for I almost said patients. You are not a patient. What I would suggest for students that live a little bit farther away, join Ring Central on your phone, put it down, so you're not looking at me while you're driving. Please don't do that. And just listen to a lecture while you're driving. If not, if you don't want to do that, that's fine. It's also going to be recorded and put on Brightspace. So you make that decision on how you want to handle that personally. I am never going to hold that time against you. Like, oh, she had to leave a half hour early from class to get here on time. Like, never in a million years would I mark you absent for 30 minutes because you had to travel to get here to take a test. Okay, never in my life. Now, if you leave 3 hours early, then we might have to have a conversation because that's not correct. Okay. So that's week 1. Week 2. We will start to go over the renal system, diuretics, drugs to treat urinary tract and bladder conditions. And then we will go into the endocrine system. The endocrine system is a pain in the B, okay? Because endocrine sucks. It's all about hormone regulation. It's all about the pituitary and the anterior and the posterior pituitary and the thyroid and the adrenal glands and the blah, blah, blah. Okay, it's complicated. I know it's complicated and I know we're all gonna hate it, okay? But we're gonna get through it, all right? So that week, we have the 2 prep-U's, we have 2 1-minute nurses, and then we have 1 practice and learn. I think the practice and learns are like the longest out of all 3 of the choices of like prep-U, 1-minute nurses, and the practice and learns. I don't know if that's true, but that's what I feel like. And then you have your ATI pharmacology practice test B. Okay. Questions about week 2? Week 3, we then go into chemotherapeutic agents, anti-infectives, antivirals, antifungals, antiprotozoals, and anthelmics. I hate that word. It's literally deworming, and I hate it. Anti-neoplastic agents. So this is all going to be antibiotics, antivirals, antifungals, all of the anti things. Okay. You will notice that I talk about zebras a lot. Okay. Zebras are your things that stand out from the rest of the pack, right? You look at the safari or whatever, and you see wild horses. Guess what you're going to see out of those wild horses? You're going to see that one zebra. Okay. So when we talk about zebras, I'm going to make sure that I am saying, this is your zebra. This is a very important thing I want you to know. Okay. So this week 3, it's the Prep-U 14, 1 2-minute nurses, or 2 of the 1-minute nurses, and 2 practice and learns. Week 4, if you notice on Brightspace, in week 4, that is the only day that your due date and time is different. Okay, because grades are due on Friday at 4 o'clock. So I can't have you turn in your prep-U's on Sunday at midnight if everything's due on Friday. So all of this stuff in week 4 is due on the 27th at 2 p.m. Okay, and that is not only in Lippincott, that is also on your Brightspace, that the dates and times are there. Okay. Let's look at our schedule. Okay. So I know this looks a little, well, you guys, I think you're used to seeing it this way, right? So this is Canton, Canton A and B. You guys, Canton A, you have clinical on the first 2 Fridays. Canton B, you have clinical on the last 2 Fridays. Okay, so please know which group you're in. We are all compliant in ACEMAP, yes? Yes. Do you have badges for UH? Yes, perfect. Niles, we have Niles A, we have Niles B, we also have Niles C. That's a lot of Niles. So, please make sure you're looking at what group you are in for Niles and when you are supposed to be at your clinical site, okay? Yeah. Oh, no, it's, yeah, we switched it to Pambele. Well, the day didn't change, but it did change to Pambele. Yeah.
Does it matter on the?
No, I could care less. There were some people that put my name for like, but like at like Cincinnati or like a campus that's like 5 hours away. I'm obviously not your clinical instructor. But I honestly, like I said, I sent out over almost 400 of them. I am not going to track who you wrote on your paper. Okay. Elyria, you guys have 2 groups, Elyria A and B, with Jefferson. Please make sure you're paying attention to where you are supposed to be and what group you are in, okay? Sylvania, I think we only have 1 group. You're at Heather Downs with Randy Van Eaton. And then Cincinnati, you're with Brett Farrell at UC, okay, on those first 2 Fridays. And I don't have anybody in Dayton. So otherwise, our entire schedule matches up, right? So Tuesday, we have class from 9:30 to 2. Thursday, we have lecture from 9:30 to 2, and then your first math exam is at 2:30. Okay? You must take it. Our very first exam 1 is going to be on Tuesday the 10th, 9:30 to 11. I'm so thankful that our exams do not start at 8 a.m. I hate 8 a.m. exams. And then we go into lecture from 11:30 to 2:30. Thursday, we have lecture 9:30 to 2. If you have to repeat your math exam, this is when you will be repeating it, is on that second Thursday. Okay? So if you do not pass your first math exam, please make sure you are making accommodations for, can you guys see my screen? Oh, okay, good. Make sure you are making accommodations for that day. Week 3, we have exam 2 on Tuesday, the 17th from 9:30 to 11. And then we have lecture afterwards. Thursday, 9:30 to 2 lecture. And then if you need to, hopefully none of us need to take our 3rd math attempt, you would do so at that point, okay? The 24th, if we do not get through, if not all, most of our content, okay? What I will do is probably on that Monday, I will have either Monday or Wednesday, I will have a non-mandatory review, okay? This review cannot be recorded. It will not be shared. If I find out it is recorded or shared in any way, shape, or form, you will be removed from this program, okay? So I like to try, I try very, very hard to do a review in the last week. And usually I try to do it on that last lecture day, which would be Tuesday from 9:30 to noon. but that all depends on how much material we get through. Okay? So, planning ahead, I may be offering a voluntary, because it can't be involuntary. I can't make it mandatory because it's not part of your mandatory hours. It is completely up to you if you join, either Monday or Wednesday. If we have a bunch of stuff to get through on Tuesday, then I'll probably have it on Wednesday because I don't want to have a review and then have a lecture afterwards. That's kind of silly. Okay. And if we do have that review, it'll be like 9:30 to like 11:30. Okay. It's going to be short. And yeah, short and sweet. Oh yes, group. Everyone is welcome. Okay. On that Tuesday, you have your ATI exam from 12:30 to 2:30, Tuesday the 24th. And then on Thursday the 26th, your final exam is from 10:30 to 12:30. Do we have any questions on where you should be, where you need to be, what to do? Any questions whatsoever about your schedule and what to expect? I want everybody to know exactly where they're supposed to be, so you're not like, oh my God, I didn't know. Okay. Okay. We covered our course overview. We covered respect and clinicals. We covered uploading everything to Brightspace. We covered our schedules, which I think I already just said. We're going to do math. We're going to get into cardiac. I say we take a break. We're going to take a 10-minute break.
I do have one question.
She has a question. Yes.
So you said, for lecture, you're gonna go over the anatomy and then the nursing board.
Yes, ma'am.
Are we gonna be testing on both?
I don't know yet.
Okay.
That's a good question.
Okay.
She said, you said we're going to go over anatomy and then we're going to go over pharmacology. Are we going to be tested on both?
Yeah, because you need to know the anatomy and how the pharmacology.
It may be, yes. I don't know. My mic is not working on my computer, but what is the ATI exam? The ATI is the ATI pharmacology. And I didn't enable it yet. Yeah, so I have to go into your cohort and enable it.
Take foundation. They've never done a pharmacy exam yet. They might not know what that is. Yeah. Some of the LPNs.
I never took one before.
Yep.
Oh, okay. So a proctored exam, but you've taken exams at the school, yes?
Same.
It's basically the exact same thing, but I don't make the test. The test is made by ATI. And the point of proctored exams through ATI is so that it can make a determination on how ready you are for your NCLEX and how you're progressing through the program. That's the point of ATI proctored
And these are
exams.
the ones we have.
That's in leadership, and we are far away from that, girl.
Okay.
But the goal is for you to get a level 2. Oh, look at that baby. Hi, Sam's baby. I love babies. So the goal, of course, is to always get a level 2. Okay. If you didn't notice, I hope you did notice, I believe it happened in December where we changed the ATI grading thing. So your practice exams are complete or incomplete. And then the whole big proctor, is you get a level 3, it's 100 out of 100. A level 2 is 85 out of 100. A level 3 is 70 out of 100. And then below a level 1 is 55 out of 100. And that includes with your remediation. That is on the syllabus. Questions about the syllabus and the grading? She said, hold up.
Question.
One second. What are you talking about?
When you take the ATI test, then you gives you like a level. So like when you get to a level.
So basically,
Oh, no. You have remediation no matter what. If you get a level 3, your remediation is gonna be a lot less. Okay, time out. Okay, if I'm assuming you have not taken a proctor yet. Okay, so when you take a proctored ATI, okay, as soon as you hit submit, it's going to come up with a score. So say you get a 73.9, and according to ATI, and I don't have my paper with me, I'm just making this up. They say that that is a level 2, okay? That means that you do remediation on your ATI, on your proctored ATI, and then you submit your report and your remediation on Brightspace. That level 2 just gave you an 85 out of 100 for your ATI. The better you do on the proctor, the higher the points you get. Okay, so if you get a 60%, but it's technically a level 2, you're not getting a 60, you're getting an 85. Okay, so let's look at the syllabus. No.
Okay, so my question is, I know we remediate practice exams. Do we remediate on the final?
Yes, you absolutely remediate on the final.
Okay, so all three. And that counts against.
Okay. Oh, yes, it's 10% of your grade. Okay, so let's go over our grading, okay? So, grade determination. So week 2 and 3, so exam 1 and exam 2 are 50% of your grade. They're both worth 25%, okay? Which equals 50%. Your Lippincott assignments, the prep use, the 1-minute nurses, and the practice and learns are worth 5% of your grade, like collectively, okay? Your ATI is worth 10% of your grade. The ATI proctored exam is a huge deal. If you are riding a 76 the whole way through this program, this class, and you get a level 1 or below level 1, you will fail the class. Okay? So it is very important that you are getting ready and studying your ATI pharmacology book, doing your dynamic quizzes, and doing your remediation on practice A and B. Okay? Because I'm telling you, if you bomb that ATI proctor, you will fail the class. The last one. I don't care what you get. So here's the thing. And thank you for saying that, because that just reminded me. When you do your practice tests and you submit a 90% on your practice, I'm not stupid, okay? I know that you used outside sources to get that score, okay? Because if you didn't, then that would mean that you're very, 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 very smart. And I think that you're all very, 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 very smart, but that you also already know all of these things. And if you do, I think that's so wonderful. And I would love to talk to you about all of your knowledge that you have. So, if you use outside sources for your test A and B, okay, and you come at me with a 90%, I expect you to say, hey, I used blah, 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 and this is where I found that information to get this wonderful score. A normal score on a practice ATI exam is anywhere between a 50 and 70%. That is normal. Okay, that is normal for you to sit there after you've studied and done dynamic quizzing, for you to sit there and literally test your knowledge. That's what they're there for. The remediation is when you look up the things that you missed and figure out where you missed and learn from that, learn from where you missed. So am I going to say, you can't do this and you can't look up? So absolutely not. But what I'm saying is that if you do use outside sources, you need to tell me that you did. Okay? because it's not fair to your peers where you chat GPT'd everything and got every answer and you got a 97% on your ATI when you have the person sitting next to you who got a 57, who then busted their ass to do their remediation and to learn from it. And you're just sitting here on chat GPT and not learning a damn thing from it. By the way, sorry about my language. I have colorful language. I'm sorry in advance. Okay. So does everybody understand what I'm saying? Okay. Everybody online, you understand where I'm coming from?
Yes.
Perfect. Any other questions about the ATI? And if you've never taken the ATI before, we can talk about it more later on when we have more time. But I want to get into content pretty soon. So we can totally talk more about it later.
Okay.
The first two, the practice A and B, are complete or incomplete. If you do not take them and do not do them, you will not be allowed to sit for the final proctor. They are prerequisites to your final proctor. Okay? So don't just be thinking, oh, well, I don't have to do these because they're not part of the 10%. They are a prerequisite. Okay? Do you have a question? We are.
You do in fact want to take a screenshot of every assignment.
Yes, ma'am. Yes, ma'am. Because I have a dying mother. I have a 3.5-year-old. I teach full time and I am your clinical coordinator. I have a husband and a house and I'm getting my master's degree. And I truly do not have the time to go into Lippincott and check to see if you did your stuff. So, and I know all of you guys have stuff going on too. So it's something that I ask of you so that we can make sure that everything is in and graded. Okay? All right. Let's take a break. Come back at 10:55.
My kids are so like respectful, they always just answer. So whenever they go out, they say like that, I'm like, I don't want to.
Are we back? Let's get things rolling.
Yeah. The chapters in the book do correlate with the chapters in the ATI. So like that's chapter 7, is it gonna be?
No.
No.
No, this is based on the Karch's pharmacology book. It's like Karch's 9th edition pharmacology. It's the same pharmacology book you used in your first pharm class. And that's the one that the Lippincott is connected to. So you have it on Lippincott if you don't have the physical book. Yeah.
Relating with here.
I like that idea. Cause I like the RN pharmacology ATI book, and I will use it sometimes. If I do, I will let you know that I used it. Like when we talk about like metronidazole specifically, or maybe it's just antifungals in general. I think I use the ATI book a lot for that because I like the way that it condenses things instead of like this big, long, drawn out chapter. Like the ATI, some of it will like condense really nicely. But then I've also found that ATI doesn't always have like all the things that I want it to have. Like sometimes it just doesn't have like things that are important that I think is important, and like why wouldn't you have it? So okay. All right, so we're gonna do introduction to cell physiology. Literally very 6th grade right now. I remember building my little cell structure with a big styrofoam ball, cutting it in half and building my little mitochondria with like a jelly bean. Okay. You will learn that the mitochondria is one of the most important parts of the cell, and we refer to it as the powerhouse of the cell. Okay? Because the mitochondria is responsible for ATP. ATP is responsible for energy production. And what do we need for energy production? We need oxygen, we need glucose, and we need amino acids. Okay? So very important, that little mitochondria. Why don't you want to do what I want you to do? So when you see the word chemotherapeutic, we're not talking about chemotherapy, okay? This is talking about chemically therapeutic drugs. So all drugs are chemotherapeutic agents. We're not just talking about chemotherapy, okay? So chemotherapeutic drugs are designed to destroy invading organisms. Huh?
Yeah, this doesn't look like anything like the one that was on Bright Space.
That's because I changed them.
Oh,
I said in my
okay,
email
I printed.
that I was changing the PowerPoints.
Oh, okay, I didn't see that in the email. Okay.
I'm sorry. Can you repeat what chemotherapeutic?
Yeah, so chemotherapeutic drugs are all drugs. Okay, they're all drugs that destroy invading organisms, which include bacteria, viruses, parasites, fungi, and then we have our abnormal cells too, which are neoplasms, which is tumors,
Okay.
and cancer cells. Okay, so it includes all of them that like to destroy
So it, okay.
things. Okay?
Yeah.
So the mechanism of action is to be effective drugs, to be effective, and drugs exploit cellular physiology in two ways. So there's either we alter and disrupt the way that the cell is made, or we prevent the cell from reproducing. Okay? So when you alter cellular function or disrupt the cellular integrity, you can cause cell death. That is called, yes, I am. That is called cell lysis. The
The death of the cell?
the death of a cell. So that what is that suffix? Lysis, Lysis. That is the medical terminology for death. Okay. So whenever we have lysis or destruction, death or destruction. So when we have cell lysis, that means that the cell has been destroyed or has died in some way. Okay. Prevention of reproduction. This is halting the cell cycle to prevent division. So remember when we learned about mitosis and meiosis, right? Where our DNA our chromosomes break up and then the cell splits and then they come back, you know,
So just stop
right? It stops it from multiplying. Okay. Can't keep track of my mouses. So our nucleus, that's the big guy in the middle, right? He controls everything. He's the master control of the cell factory. Okay, he's the guy in charge. He holds the DNA. So each cell operates on a preordained program that's produced by its genes. It stores our DNA that is necessary for cell reproduction. Okay, and it dictates the production of specific proteins. Our cells are made a lot of amino acids. We have to have amino acids cell structure. Okay. And then synthesis, which directs the ribosomes based on genetic sequences. So genetic programming allows for the cell division and the maintenance of the cell. So we are constantly always in a balance of homeostasis. Our bodies, every second of every moment out of every single day that you are sitting here alive, we are constantly trying to achieve homeostasis. And that goes down to the absolute smallest cellular level. Okay? We can talk about homeostasis on the big grand scheme of things, but we can also discuss that that homeostasis literally occurs at the cellular level. Okay? So this picture should look like very much 6th grade. Okay? So this is the cytoplasm with all of our organelles. It's what we call the little guys inside of the cell floating around, right? I do not need you to know these things. The most important thing that I do need you to know and that I want you to remember forever and ever and ever is that the mitochondria is that big. Okay? We can't live without her. Mitochondrial diseases are really rare and they suck. Okay? They're really hard to live with a mitochondrial disease when you have a deficiency in mitochondria. There are very rare diseases that are not viable with life if you have 0 mitochondria. Okay? There is specific things that are passed from mothers to babies specifically by the mitochondria. Okay? So yeah, the nucleus is like, you know, you ever hear that where, what show was it? Where it was like the head of the house like makes the decision and that's like the man. but the woman is the neck and tells it where to turn. I forget I feel like it was my big fat Greek wedding. I really feel like it. I don't know and I don't remember, but valid. Okay. So if we think about it like that, yes, our nucleus is like super important. Like he's in charge, right? That's the brain. But the mitochondria is the guy behind him doing all the work. He's us worker bees. Okay. So our cell membrane, depending on the cell itself, can be different in some ways, but majority, we have phospholipids, we have glycolipids, we have cholesterol. And through these things, we have amino acids, okay? They all come together to build the cell wall, all right? So phospholipids are arranged in a bi-level polar. So these heads, the circles, okay? That is the exterior of your phospholipid layer. And then you have the interior of these lipid guys, the tails, that are we have hydrophilic and hydrophobic. Hydrophilic means I love water. Fill me with water. I love it. Okay. Hydrophobic, get it away from me. I have a phobia of you. I don't like you. Get away from me. Okay. So phospholipids have bilayers where the outside likes water, the inside no water. Okay. It's a protective mechanism and helps with diffusion of things across the cell membrane. Okay. So if we remember, some things diffuse over a radiant, like if I had perfume and I sprayed it over here, it is going to diffuse across the room from the highest concentration of where I sprayed it to where there's no concentration over there. But eventually it's going to diffuse where you can smell it over there, right? That is diffusion, okay? But not all things can just diffuse across a membrane. Some things need help, and we call that active transportation, where they need help crossing the barrier, okay? So we have these glycolipids, which are carbohydrates attached to lipids. And then cholesterol is embedded within the tail region to provide stability and fluidity. So, and then these guys, these little sausagey guys, these are for active transport across the cell membrane, okay? And these are usually your amino acids, your proteins, okay? Because some things need to bind to protein to be able to pass through a cell. Okay. Oh, and very important concept is that whatever's inside the cell is our intracellular fluid and the components of the cell, so the organelles. So intracellular is the fluid inside the cell. Extracellular is everything outside of the cell, your blood serum, your extracellular ions like potassium and sodium and all the other ions, okay? Your platelets, your white blood cells, those are all in your extracellular fluid, okay? Now, when we talk about the transport of ions, they have to cross between the intracellular and extracellular. But how do they do that? Some of them pass freely. Some of them pass by the sodium-potassium pump, right? Where there has to be an exchange, like a teeter-totter, okay? So it all depends on how the cell is going to allow the transportation. So we also have what's called receptor sites, okay? So I remember thinking about like Tylenol and thinking like, how does Tylenol know that my head hurts? How does Tylenol know that my toe hurts? Like, how does it know where to go? It's not that it knows where to go. It goes towards your pain receptor sites, okay? And it attaches to the pain receptor sites to turn off the pain or lower the pain. Okay. We have receptor sites everywhere, whether they're opiate receptors, prostaglandin receptors, your baroreceptors in your arteries. There are receptor sites everywhere. Your serotonin, dopamine, norepinephrine, all of those neurotransmitters work with receptor sites. Okay. And that's how they know where to go. Because I have a hat and my hat goes to this receptor site. It doesn't fit in any other receptor site. It only fits in the one that I belong to. And that's how drugs, or really anything, get to where they need to get to. Okay. It doesn't just go to the toe, it goes to all of them. Okay. So receptor sites are surface proteins that react with specific chemicals to trigger intracellular responses. Histocompatibility, antigens, big word, but we know that there's a difference between antigens and antibodies, right? So antibodies is me saying, I'm an antibody. You have had chickenpox. And your chickenpox virus has an antigen hat, wearing an antigen hat. And because your body has already seen that hat, it has made an antibody for it. So when my body, my immune system says, you don't belong here, I know how to beat you. It then can produce the antibodies that can fight that specific antigen. Okay? Go ahead.
Okay, so the antigen is,
The bad guy.
so it just.
Sometimes.
So it just see. So when you're infected with something, that's the,
Yes.
and the antigen,
In this concept, yes.
and the antigen is just always there once you're infected with it, like it's all.
No.
memory or.
No, we have what's called memory T and B cells in our immune system, and they remember antigens. So we're not always producing antibodies against varicella, the
Okay,
chickenpox,
That's what I was.
right? We're not just always making it. We keep that in our back pocket, our filing cabinet, until we need it. Okay,
So the antigen is the effective agent.
in this concept, yes.
Like they were doing, so that antibody test, and that was basically to determine if you had COVID.
To see if your body had already.
Like it was,
So she's saying that during COVID, we made like antibody tests. And it was a way for us to be like, okay, you have antibodies against that
So
COVID-19
you had
virus.
so for my.
Yes.
It would show she had it.
Yeah.
If that makes sense.
So self-identification, this allows the immune system to recognize the self cells. So this is me saying, hey, I know you, you live here, I'm not gonna attack you. Okay? But what happens when that goes wrong? What do we call it?
Autoimmune.
Autoimmune. When our cells, our immune cells start attacking what is supposed to be identified as our self cells. Okay. So normal is like, hey, you're my neighbor. I know you. I don't want to beef with you. Abnormal is, I don't know you and you don't belong here and I'm going to kill you. Okay. Abnormal response to a self cell. Defense, this enables the immune system to identify and destroy the non-self cells. So the invaders, the viruses, the bacteria, the bad guys. Okay. We talked about a little bit about like, this is calling it pores. So pores within the membrane that allow for the controlled passage of substances.
So the ATP.
So remember, there's a lot of different ways to cross the cell membrane. right? We could do it by amino acid channels. We could do it by a pump like the sodium potassium pump. We could do it by osmosis or diffusion, okay? It all depends on what the substance is and how the cell wants to accept it. Whether it needs energy to pass through. So if it does need energy to pass through, that's our active transportation. It needs energy to get through. Passive, I don't need energy, I'm just floating by. Okay. So we talked a little bit about homeostasis. We're going to talk a lot about homeostasis forever and ever. And when you see me again, we're going to talk about homeostasis because homeostasis is balance. It is how we survive. Okay. So we maintain the stability through traffic control, which is regulated by the cell membrane. Transport systems, like we already discussed with active and passive transport, and a waste management system where it disposes of the yucky stuff. Okay.
From inside the cell.
From inside the cell, yes. The goal is keeping the cytoplasm stable, which the cytoplasm is the intracellular fluid, right? Despite the changes that are happening in the external environment. Okay. So when we're talking about moving large, what is the word? Particles through the cell membrane, we have endocytosis, which is grabbing onto something and kind of absorbing it into our cell, right? Through it's, hey, I see you, I'm gonna wrap around you all the way, and then I'm gonna bring you in, okay? Endo, the word endo means within. Cyte means cell. Osis is a condition or something that's happening. So there's a condition happening within the cell. This is why medical terminology is so important. Okay. Exocytosis is how we export things. So this is, I want what's in my cell out of my cell. Okay. Can everybody hear me? Because I think my hotspot got disconnected.
Yeah, I can hear you.
Yes.
Yeah.
I can hear you.
So this is a way to remove substances like hormones, neurotransmitters by pushing them through the membrane. Okay. So is this active or passive? Both. It looks like they're working. If I'm working to do something, I need energy. And where does that energy come from? The mitochondria.
Okay, so the active, okay, can you explain the active?
Active transportation is when I need energy to do something.
Okay.
Passive is when I'm just floating by in one of those lazy pools. What are they called?
Okay.
What are they called? Yeah, like a lazy river. I'm just floating along. I'm gonna get to where I'm getting to eventually. Active is when I put a motor on my little floaty to get me from A to B faster.
I have to do backwards.
That's right. This is passive transport. This is movement without energy. This occurs across semi-permeable. Permeable. What does that mean? Things can come through. So if it's semi-permeable, I'm saying, hey, you can come through, but I don't like you and you're not coming through, right? It can also go by the size of the molecule. So semi-permeable could be have you, wait, I've never owned one. I've only seen one in recipes. But like you have a strainer, right, that has like bigger holes, and then you have like a really small strainer that has little tiny holes, right? So it has little tiny holes or big holes, both are semi-permeable because I can only get through certain parts of it and only when it allows me to, or if I fit. Does that make sense? Okay. So diffusion is something going from a high concentration to a low concentration. Like if I spray an aerosol or a perfume or a fragrance that goes from high over here to low concentration all the way over there. Okay. Osmosis is the movement of water. Did you ever hear the term that water follows salt? That is a very important term to remember throughout your career because it is always going to be true. Always. Water is going to be drawn towards the particle. Okay. And facilitated diffusion, it's assisted but passive. So I have this hole here, this pore. It's only big enough for this one friend and smaller friends, but I allow them to come through passively. They don't need energy to come through. They just kind of float through my little channel here, like a tunnel. Okay. But nothing's stopping them. They don't have to work for it. Through the tunnel. Okay.
Only allows a couple, it doesn't allow all of them.
Active transport. This is powered movement. I need energy to do this. This requires energy in the form of ATP. ATP is made in the mitochondria. Okay. So this moves against the concentration gradient from low to high. I don't care if there's none over there and there's a bunch over here. I'm working against the grain here. I'm fighting to get where I need to go. Okay. I need the engine attached to get there. So a primary example would be the sodium potassium pump, right? So I need to give something to get something back. Okay. In this active transport. Some drugs hijack these activities or these active systems to force entry into the cell. So sometimes when we need to facilitate this process, we give drugs that forcefully break through the door. Okay. That makes sense? Maybe a little bit. Okay. I don't really care about this, but there are phases of the cell cycle, right? We constantly are reproducing our cells through mitosis. And after mitosis occurs, so if we think about, remember when we learned about it in science, there was a cell, and then within the cell, there was the chromosomes, and then the chromosomes split apart, right? That is gap 1. Gap 2 is when they replicate the chromosomes. Or I'm sorry, that's the synthesis. I called it gap 2, that's not true. That's the synthesis. And then gap 2 is when we prepare to divide, all right? Then we have the act of mitosis, which is actual division. And then we chill for a minute before we go back into a reproductive stage, okay? That is the primary reproduction cycle of our human cells. Okay? There's a lot of different types of cell division, but not for humans. We do mitosis in humans. I literally just talked about that. So we have to have directions in order to be successful in our cell replication. Okay. So the genes in the nucleus program the cell for specific protein production and division. It's already done. It's already talked about. We already have the plan. Okay. We have a barrier. The membrane uses lipoproteins for structure and antigens to identify the self versus foe. Okay. The economy. Homeostasis is maintained via passive diffusion and active energy dependent pumping. So we have both active and passive ways to come across the cell membrane. And then of course we have the life cycle. The cell follows the rigid life cycle to replicate. And if we need to disrupt that replication, that's where our chemotherapeutic drugs come into play. Okay. Questions on the basics of the cell?
No.
Beautiful. This is a good example why I wanted you to have it in front of you on your computer, because this is really small and hard to see from so far away. Is this the one I want to go to next? I think we're gonna go to the next one. Okay. So. In a field, I love this. If you have never used Notebook LM, you really should start because it's pretty epic. And I'll be sharing my Notebook LM thingy with you. So probably some point this week. So the core philosophy is that in a field of antelopes, you want to look for the zebra. So the one thing that sticks out to you, okay? Because it's really easy for all of this information to just blur together, especially when we talk about antibiotics. It's like, okay, is it the liver? Is it the kidney? Like what? Like it all just blurs together, okay? So the goal is that we're not just memorizing for an exam, that we are creating core memories for you to take with you throughout your career. That is the main goal. So, the standard rules and suffixes when we talk about drug classification is that we have the classification of drug, which could be for cardiac, ACE inhibitors, calcium channel blockers, ARBs, and many more. And then we have our suffix. So ACE inhibitors all end in pril. Okay. Lipid lowering agents all end in statin, like atorvastatin. Okay. Now, there will come a time where they don't all follow this pattern, which becomes annoying. But the general rule of classification is that they have a suffix that matches. Okay. So the zebra is the outlier. It behaves differently or carries high stakes risks. So for example, most calcium channel blockers affect the blood pressure, but there are two calcium channel blockers that are different. You have diltiazem, which is cardizem, and you have verapamil. And they both work more as an antiarrhythmic than they do as a hypertensive agent. Okay, which I expect you to know, by the way. So the big three for every drug is MOA, the mode of action. Okay, so the mechanism of action, how does the drug work? How does it work physiologically in the body? Adverse effects, what happens when things go wrong? Are they gonna kill you? Are you just gonna be a little itchy? Are your eyes gonna pop out of your head? Is your left toe gonna automatically like swell up like a balloon? Okay. So, and then contraindications, when do we never give this drug? Okay. Contraindications are very important when it comes to drugs. They can be drug to drug contraindications. It can be lifestyle things. It could be dietary. It could be disease related. Contraindications could be a lot of things. Yeah. So when we talk about drugs, you want to remember that it's always going, because we're going to see a lot of adverse effects. And you may be sitting here like, why in a million years would anybody ever do this? Like, why would you put this in your body? And it's because the benefit for that patient outweighs the risk. Okay. And it always comes down to that. So when we talk about the heart, I did this specifically because I do not want you to come to complex care and say, I've never seen that before and I have no idea what you're talking about, because that's really going to make me mad. Okay. So this is our heart. It's a beautiful heart. Okay. We have the right atrium. The right atrium goes through the tricuspid valve. Yeah. Through and into the right ventricle. The right ventricle then pumps and goes into the pulmonary artery. And you say, Jessica, why would it go through the pulmonary artery when it's deoxygenated blood? Great question. This is the only part of the body where arteries and veins are flipped, right? So every day, every part of our body, arteries carry oxygenated blood, right? Veins carry deoxygenated blood, not in the heart, not in the ticker. From the right ventricle, which is deoxygenated blood, goes into the pulmonary artery, which take it to the lungs to become oxygenated. Once that oxygenation occurs, we go back to the left atrium, where we go through the mitral valve into the left ventricle, where then it is pumped to go through the aorta and out to the rest of the body. Okay? When we talk about the cardiac conduction system, you know when you put your patient on telly and you see the little lines? Those lines are important. That is the electrical activity that is occurring within the muscle of the heart. It's important because muscle contractility, electrical conduction can be changed by the drugs that we give. Okay? So the normal conduction of the heart is the SA node, which is the sinoatrial node. to the AV node, which is the atrioventricular node, to the bundle of His, where it meets in the middle, which we call the septum, down to the Purkinje fibers, which then wrap around the right and left ventricle that cause contraction. Okay? So if there's something wrong with my electrical system and it's not going the way it's supposed to go, I got to do something about it. Okay? So the SA node is known as the pacemaker of the heart. This is the node that says 60 to 100 beats. Boom, 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 boom. It sets the rate. Okay? The AV node we call the gatekeeper. This is where we take a pause because the atria and the ventricles cannot contract at the same time. If they contracted at the same time, it wouldn't work right. The atria contract, pushes blood into the ventricles, but the ventricles have to be relaxed for them to accept that blood. Okay? And that's where the AV node comes in, where we can relax for a second, just for a second, so that we're not contracting all 4 chambers at the same time. Okay? Automaticity is the heart's ability to generate its own electricity. If you have a normal sinus rhythm and your heart ba-boom, 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 all by itself, then you have wonderful automaticity. If something's wrong with that conduction, yours kind of sucks. Okay? And we need to do something to fix it. Contractility, this is also referred to as Starling's law, is that when something is stretched, we call them stretch receptors. It causes the, not the ability, but the action of contracting. Okay? The uterus works in the same way. When the uterus feels stretched, it wants to contract to force it out when we're in labor, right? It being the baby. Okay. So Starling's law is the heart pumps harder when it's stretched. Okay. So when we fill the balloon says, hey, I'm full, and it's going to contract. Cardiac output is stroke volume times heart rate equals your cardiac output. This is something that you should know for like ever. How to figure out cardiac output. Okay. Why it matters. Pharmacology manipulates the specific electrical phases and contraction strengths by the drugs that we give it. And every drug is going to work in a different way, which is why we have so many of them. Have we heard of the renin-angiotensin-aldosterone system? Yes?
Yes, but
Yes, but no.
yeah.
Love that.
Okay.
I love that. Okay. So, and we'll get into this a little bit more. I'll talk about the RAS system. But when we talk about drugs that affect the blood pressure, we are talking about how it affects the renin-angiotensin-aldosterone system. Okay. So ACE inhibitors like Pril, like lisinopril, captopril, and enalapril, blocks the conversion of angiotensin. And I'm going to show you where all of that occurs. ARBs also block something within the RAS system. Okay. We have angiotensin 1, we have angiotensin 2, we have angiotensin 3. It's where exactly we need the interruption to occur, is what drug is that we're going to choose. Okay. I want you to put a little star right next to our zebra and a little star right here next to my ARBs. Okay. So My ACE inhibitors end in pril. My ARBs end in sartan, valsartan, losartan. Okay. The biggest black box warning for ACE inhibitors is angioedema. Angioedema is rapid swelling of the lips, mouth, neck, face, all of it. This is what happens in an anaphylactic reaction, angioedema, okay? Specifically, when we talk about angioedema related to lisinopril, what's important to know is that it can happen at any time. I don't care if you've been taking lisinopril for 1 day or you've been taking it for 20 years, okay? My dad has been on lisinopril for like ever. And one day I had just started my nursing career and he texts me, my dad's a drunk, by the way. So most things don't make sense. And he's kind of dumb. So he calls me and he's like, there's something wrong with my face. And I'm like, what are you talking about? He's like, I woke up like this. I'm like, okay, send me a picture. He sends me a picture. His face, like literally, it looks like there's a freaking softball on the side of his face. And I'm like, dude, what are you doing calling me? Go to the ER. Like, what are you doing? So one of their very first questions was, do you take lisinopril? And he said, yes. It ended up being a dental abscess. But their very first thought was angioedema because the swelling was insane. It was crazy. Okay. Also, one of the most common adverse effects of ACE inhibitors is this dry, unrelenting, super annoying cough. And what happens when you take a drug and you don't like what it does to you? You stop taking it. What do we call that? Non-compliance or adherence. Non-compliant. Okay. The patient is non-compliant. We say these things all the time. They're non-compliant, okay? This is one of the biggest reasons, the cough, the dry, unrelenting cough is one of the biggest reasons why patients are non-compliant with their ACE inhibitors. ACE inhibitors also put your patient at a higher risk for hyperkalemia. What is hyperkalemia? High potassium. Will a cough drop help? I don't know. So ARBs do carry a risk for the cough, but it's lower. People that can't really tolerate ACE inhibitors kind of go to ARBs afterwards. If you have already experienced angioedema with lisinopril or captopril or enalapril or any of the prils, you are very likely to experience it again with ARBs. And you can experience it just from ARBs. It's just more common with ACE inhibitors. Okay? So you're at risk for angioedema with both drugs, just more at risk with ACE inhibitors. How do they stop the angioedema from averting inhibitors? And do they have to rush to the ER? So if angioedema is significant, the patient will have, and you have a compromised airway, that patient will be intubated, okay? It very much is treated like an anaphylactic reaction. It is a type of allergic reaction that occurs, but the weird thing is that it can happen at any time. And you say, Jess, but technically allergies can develop at any time. Yes, I agree. But this angioedema with ACE inhibitors, it's just different. It's weird the way that it happens, and it's directly related to the drug category. So we treat it a lot like an allergic reaction,
Okay.
where we have our steroids, we have, I mean, God forbid if we need epi. Like if I were, say I was just out in the wild, my kid has an EpiPen because your girl has anxiety, okay? I have a lot of anxiety. I'm a Lexapro girl, right? I love Lexapro is my girl, okay? So when Henry started to, need to eat food, and the doctor was like, give him eggs and give him peanuts. And I was like, ha, you're so funny. How about no? They gave me an EpiPen because it was like, hey, you're a nurse. You need to be able to like do the things that you need to do if you need to do it. I was provided education. Does my child have any anaphylactic reaction to anything in his entire life? No. But do I have it? Yes. So if you were to go into angioedema right in front of me and you became stridorous, which means I can hear you breathing from across the room and you're like, I'm going to give you epi so that I can open your airway and call 911 because I'm going to save your life. Okay. Is it necessary with every situation of angioedema? Absolutely not. Absolutely not. But when my airway is compromised, you're damn sure I'm going to give you epi and I'm going to try to save your life while I'm calling 911 on speakerphone. Okay. We're going to go to lunch in 10. Oh, this has a little something, a little snippet at the bottom here. Nursing action, you want to monitor the potassium and blood pressure and watch for what's called a first dose phenomenon, which can cause severe hypotension. It is not common, but it can happen.
That's not common.
It is not common.
That's for the ACE inhibitors or both?
Both. ACE inhibitors and ARBs are some of the most commonly prescribed medications in this country. Okay, I want to see. I want a video. Need videos. Want a picture. Makes sense. Easy to follow. Oh, I want a video. Okay. The renin-angiotensin aldosterone system. It all starts in the liver. Okay. The liver produces angiotensin. And gets converted into angiotensin 1. Okay. I don't like this. You know what? We're going to go to lunch. And I'm going to find the picture that I want so that I can explain this in the way that I want. So let's go to lunch. Let's come back at 12:30. And we will continue. Right? It's 11:53. I mean, is that too much time?
No, that's fine.
I mean, I'll lower it. Okay, well, Jessica needs food. So
12:30 is good.
please do not be late because I will start without you.
Hmm.
working overtime. I have much on they know only show like eight pairs that you cannot fix with it. She says handle all of that. Ooh. It's a lot, but I'm really excited for pharmacology today. I feel confident. Now, it's something you're gonna want from, so just review, keep practicing. It's my first time that we Thursday. And then just make sure one side. One side of it, I think that's good. I have that figure something out with how to study. There's three sets. I don't really need all three. You know, honestly, I think it's part of that bug, and that would make sense. Both of them want to sleep so much, because I feel like I have to draw. That's what I'm trying to keep moving. Hey, Mom. There's a cheese pizza, a bacon chicken ranch, and a buffalo. There's the cheese. And whatever you think it like, I mean, right now, I feel like I could just eat the cheese with her. Same. So just do the cheese? Yeah. Oh, and this one? She says, and make sure that your camera's on. If your camera's not on, you'll be leaving my classroom. She says, I don't care if you're online or if you're in person. If I don't like your behavior, I will kick you out. She said, I am devoting my time to this. I want to see you all succeed. She says, and it's a mutual respect thing. If you don't have respect for me, I don't have respect for your education. Learn from your own.
Cheyenne, your microphone's on.
Good.
Hey Jess, do you mind if I finish eating my sandwich
Do I
off
mind
of
what?
camera?
I can't hear you.
Do you mind if I finish eating my sandwich off of camera?
No. How dare you not eat your sandwich in front of all of us?
Well, it took me
I
a long
must
time to make.
see the chewing, the mastication. Please don't. Please don't. I will be so upset. I'll have to kick you out. Just kidding. Just kidding. That's one way to get out of this.
Wait, so you're saying I can go home if I chew in your face?
Ooh.
I ate 5 bites in a pool. Have a gastric sleeve like me?
Do I have any bariatric girlies in here? I am. March will be 3 years. Yeah. And I had skin removal a year and a half ago.
Well, you look great.
That's what I was thinking.
I've lost 100 pounds twice in my life.
That's
Yeah, before my wedding, I was like hardcore keto. Before keto was cool.
yeah.
Back in 2018. And then I gained it all back more. Well, and then I did IVF and
Yeah.
hormones.
And then babies and all that part.
Oh, I was 300 pounds when I delivered my son.
I can't see it at all.
I'll show you. I'll show you. I had a tattoo
But you're
this big, and all I have left of it is that.
just that little bit.
Shut up! Yeah, I'm not kidding. He removed 7 inches of skin. Yeah. Oh, and oh boy, that muscle repair was strong. It's worth it though. It's worth it. It was a really hard recovery, but I don't
Ours
regret
is
it.
still kind of in a stall. So.
I had a well, which part? I had a gastric sleeve. And then I had a tummy tuck with muscle repair. With the removal of a lot of skin, and I also had a without implant.
How much time did you have between having the surgery?
So I had my gastric sleeve March 7th of 23. And I had my skin removal June 27th of 24.
Okay.
So it was like a year and 3 months, maybe after.
Well, you look hot. Listen, once I get through nursing school, I'll get back on track. I've just been stalling like this week.
My stress is making me gain this weight. I know it.
I mean, I've only gained
Listen.
5 pounds.
Will do it, my friend. I can't afford it.
I was down to 100 off. I was 188. I'm at like 193. Just hang
All
on.
right, are we ready?
But we can be.
I never stopped recording. So
They don't know
I
the story.
usually don't do breaks in recording unless the video if the video is over 5 hours, it gives me trouble downloading and then it takes forever on YouTube like to download to YouTube. And it's not even the downloading to YouTube, it's the processing on YouTube that takes forever. So if my recording is going to be anywhere like more than like 4.5 hours, I will usually like pause it because then it just causes trouble, causes drama.
Do you get views on YouTube? Get paid?
Oh.
I'm just saying.
No, so what's hard about the YouTube thing is I have to be very careful because HIPAA is still a thing. And also the recording on Ring Central, like their faces are on it. So I can only make it public to share the video like into Notebook LM and then onto Brightspace, but then I have to make it private because of HIPAA. So I can't have like a public channel with like everybody's faces on it unless like everybody like signed consent, I guess would be a way to do it. But that just feels like a lot of drama that I don't have time for. I think we've established I don't have time. I just really don't have time. She is unwell. No, I don't mind at all. Is there anybody back? So my mother was diagnosed with stage 2 breast cancer when I was 10. She was 38 years old. And she had a double mastectomy, reconstructive surgery. She actually had a gastric bypass a year before, and was one of the only reasons that she was like successful in finding her tumor so quickly because of the massive weight loss. And cancer, by the way. That first time she went through like really, really intense chemo, like hair, radiation, everything just like really bad. And they found out that she has a very aggressive form of breast cancer, but it's also I don't know the word, perceptive, which isn't the right word, to a specific chemotherapy agent. Receptive, yeah, whatever, you know what I mean. Her tumors are receptive to a very specific chemo. So once they found the right treatment, her tumors would, go like basically go away. And then every time they would take her off, she would have tumors just like pop up. Like she had nodules like in her neck once. She had inoperable tumors behind her heart. She had nodules in her lungs. So 2 years ago, she was diagnosed with an inoperable brain tumor. And the thing about the brain is we have what's called a blood-brain barrier that protects our brain from a lot of drugs specifically. So it kind of ties in a little bit. Not all drugs can cross the blood-brain barrier, which is why brain infections are sometimes really hard to treat because we can't get the right thing to get into the brain. So they did radiation on her head for a while, like multiple times. And then she was also doing they did find like a maintenance chemo that was okay, but like she progressively declined over the last year, like bad. And then probably about 3 weeks ago, she had an echo. If you don't know what an echo is an ultrasound of the heart, and it shows, basically it shows your cardiac output. It shows the blood flow through your heart. And I'm going to teach you this in a couple months, but so say, your left ventricle holds 100 mLs. It's normal. The normal function of your left ventricle is to be able to pump out 55 to 70%. So 55 to 70 mLs of that 100 mLs, right? That's normal. So I didn't know this. I've never worked strictly in oncology or as a chemo nurse or anything, so I didn't know. But once this is called your ejection fraction. Once your ejection fraction falls below 50%, you're no longer a candidate for intravenous chemotherapy. I didn't know that. Never taught that as a nurse, so put that in your back pocket. So that happened about 3 weeks ago. She had a cardiology appointment and they wanted to start her on, I think it was like Farxiga, which is a fancy combination cardiac drug, which I don't even think we talk about. Metoprolol, which is a beta blocker, and something else. I can't remember the third, or Coric. And it was supposed to help with like her cardiac output and contractility to try to get more cardiac output to increase her ejection fraction. And they thought about it, but my mom lives an hour away. She lives in Austintown. And we've already established I'm busy, very busy, unfortunately, and I can't just like run down the road. It's an hour drive. Her boyfriend has no medical knowledge whatsoever. So he was like, I don't know what to do. Like, if I give these meds, like, how do I know if her blood pressure's okay? How do I know? Because metoprolol, you're going to learn, our beta blocker, works more on your heart rate than it does your blood pressure. Okay. So it's more important to know your apical pulse over whether your blood pressure is a little soft, right? So as nurses, we have to think about these things when we give or not give these medications. Well, Joe has never taken a blood pressure in his life. Like he doesn't even know what that means, basically. I mean, the guy's a great guy. He's a wonderful man. He's taken care of her for many, many years. But he also is a truck driver and he's never taken a blood pressure ever. So they were going to have nurses like kind of come in for like home visits to do whatever. Well, a couple of days had gone by and my mom, the more she didn't receive treatment, the more encephalopathic she got, which means her swelling in her brain got more significant. And she gets really confused. It's really hard to like even have a conversation. Like she cannot really speak like a full sentence. She lost function of her right arm like 3 months ago, and now the swelling is so bad that she can't even move her right leg. So he kept checking in with her, like, do you want to do this? Do you want to do this? And she was just like, I'm tired, like I'm done. Which I mean, it's been 24 years. Like like we all knew it was going to happen, but like it's happening. After 24 years, it's like, yeah, it's going to happen, eventually. I always joke that like my mom is like a cat with 9 lives. Like she just won't die. And unfortunately, we have gotten here. And so in the last, like we literally just started hospice like a week ago. Not kidding, like literally a week ago. And he called me this morning and said, like she was basically unresponsive and like in the middle of the night and she couldn't take her meds. So he called the hospice is so good. If you ever find yourself, a lot of people look at hospice as like endgame for their nursing career, which is great, whatever, but if you ever have a calling for hospice, like it's such a beautiful thing to be a part of, to be allowed to be a part of someone's death and transition. Anyways, the hospice nurse came out at like 2:00 in the morning and she taught him how to like make the pills like a paste, like not even liquefy, like into like a paste that he could put under her tongue, which I found very interesting. I've never heard about that before. And I've never done hospice nursing. So the nurse said that they're going to have nurses come out every day now. And usually at this point, death usually occurs within the next 7 days. So her family is coming in on Thursday from like the Philadelphia area. And yeah, my brother's a mess. Not good. Not good. Yesterday was not a good day for me at all. Everything was like super heavy yesterday. Today as nurses, we learn how to compartmentalize. Like that's how we have to get through our days and our shifts. I mean, literally there may be a day where you code one patient in one room and then you go pass meds in the next room. And that's real life. Like that's nursing. So I am maybe okay. But yeah, that's what happened. So yeah, it sucks. It sucks. I'm guessing by the time you see me on Tuesday that my mom would have passed by Tuesday. I know, it sucks. I'm not working tomorrow. I am planning on doing your lecture on Thursday because I really don't like when people, like I've never missed one of my own lectures ever. and I don't want to. I don't like the vibe. I know, I just don't like it. I really would prefer to teach my own material because I only test you on what I know that you know, what I know that I taught you. And that's not anybody else's responsibility but mine. You know, so I'm not planning on missing Thursday. But if it happens, then we will take that as it comes.
Did your mom's mom have breast cancer? Was it-
Yes. So my grandma had breast cancer. She had a lumpectomy. But crazy enough is that our breast cancer is not hereditary. So because of the history of breast cancer in my family, my risk percentage is 37%, which is absolutely insanely high. And I go to the Summa Breast Center for their high risk breast stuff. And because of my high risk, I get imaging twice a year. I get MRIs every 6 months and mammograms every 6 months. So they are very, they watch me very closely. I almost, because we talked about when I had my breast lift, before that, I was this close to having a prophylactic mastectomy. But because my BRCA genes came back negative and because they looked at her gene, her DNA sequence and my DNA sequence, like we didn't match at all. So I was not, I mean, I could have still done it, but it didn't make sense, like to the breast surgeon, like that's overkill, like don't do that.
So your mom had a mastectomy and still got cancer like after what?
So that's the thing she has a very aggressive cancer.
So like it just-
And when you talk about cancer, because I mean, we are going to talk about cancer and neoplastic agents. Cancer, when we just talked about cell physiology, right? Cancer happens when the replication of a cell goes wrong. So and your cells are microscopic. Like one teeny tiny little cell is microscopic. So if you leave one behind, just one out of millions, then you can have metastatic cancer. You know? Yeah, cancer is scary. Okay. We need to get back on. Did you take the BRCA? Yes, my BRCA was negative. Thank God. I was surprised, to be honest. I was very surprised. I was ready to cut him off. I'm not kidding. I was like, I had talked to my husband multiple times, like, I'm telling you, I'm cutting him off. And he was like, it's okay, you're fine. Because my mom was 38. I'm 34 with a 3.5-year-old. I know what it's like to be raised by a mom with cancer for most of my life. I don't want to do that to my kid. Anyways, this is the RAS system. Do you have it pulled up in front of you? Because this is really hard to see. Okay.
This is okay, I'm gonna take a picture. Can you film my phone?
I'm gonna try.
Send it to you. Gotcha.
Okie dokie. So, what happens here is have you ever heard of a negative feedback system?
Yes.
Okay. Everything in our body works by a negative feedback loop. Everything. Except for childbirth. That's a positive feedback system, but we're not talking about that. Everything else works by negative feedback. That means our bodies wait for something to not be right, and then it says, okay, what can we do to fix you? Okay. So in this case, I am hypertensive. Okay. My blood pressure is 160/97. Okay. And my brain says, hey, I don't like that. Please don't do that to me. And it says, hey, kidney, what you doing? You want to kick in here? You want to do something about this? So our adrenal glands, they live on top of our kidneys. Okay. Your kidneys are half responsible for your blood pressure regulation. Okay. So your brain says, hey, I need you to do something about this. So hold on, where am I starting? I got lost for a second. Wait, where am I starting? Okay. So my brain says, hey, blood pressure's high. I also have receptors inside of my arteries that know it can sense the vasoconstriction causing the high blood pressure, right? So my liver says, hey, no good, okay, and produces angiotensinogen. Angiotensinogen becomes angiotensin 1, which is converted in the lungs to angiotensin 2. This is very complicated, very sciencey, okay? Angiotensin 2 goes to our vessels, our arteries, and tells it to vasodilate. Vasodilating is going to cause the blood pressure to go down, right? And then it's also going to tell my adrenal gland, hey, you should release aldosterone. Aldosterone, when released, tells our body to water through the kidneys. Okay. So with vasodilation and the release of water, which volume, okay, in our bloodstream is going to lower the blood pressure. This is what's supposed to happen. This is what regulates our blood pressure at every second of every day. But what if something goes wrong? Something is telling our body to be hypertensive and my compensation, my negative feedback loop is not working. So then I need to give drugs that are going to make it work. So we have these cells in the kidney called juxtaglomerular cells. Okay.
Is that in this packet or not? That picture?
I'm going to put it on Brightspace. So, and when we talk about renal, we'll talk about that too. So when you look at a kidney, right, you have the kidney, and then you have all the spaces in the kidney that kind of look like little flowers or something. Those are your nephrons, okay? Within the nephrons is your glomerulus. Your glomerulus is where all the filtration happens, okay? So when we have decreased perfusion in the juxtaglomerular cells, it says, I need to increase my blood pressure. So now we're going to increase. So the liver produces the angiotensinogen. That gets converted into angiotensin 1 to angiotensin 2. The activation of angiotensin 1 to angiotensin 2 occurs in the pulmonary capillary bed of the lungs. I know this is, you're all just like, what is happening right now? I get it, okay? So then angiotensin 2 goes to my arteries. And that's where it works within the arteries, okay? So my ACE inhibitors, what does ACE stand for? So is it what part of my RAS system is it working on? Because I have renin, which is here in my liver. I have angiotensin, which goes from my liver to my lungs to my vessels. And then I also have aldosterone, renin, angiotensin aldosterone system. So if my ACE inhibitor is working on my angiotensin, then it's got to be working with somewhere within the liver, to the lung, to the artery, to the adrenal. It's got to work somewhere here. Okay. If my blood pressure medication is working on aldosterone, then that means it's working at step 5 in my adrenal gland, where aldosterone is excreted. If it's working on the renin, it's working all the way over here at the beginning in my liver. Well, that depends on the drug. That depends on the drug, my friend. Okay. So, do I need you to know this? I want you to know that the kidneys and the adrenal glands have a huge, huge part in blood pressure production or maintenance. Okay. I need you to know that angiotensin going into the arteries is what's causing your vasodilation so that your blood pressure can go down. Okay. I want you to know that aldosterone is going to make you pee. Okay. So the more aldosterone my body is producing in this system, the more I'm going to pee out the volume the excess volume I have. That makes sense?
Could you say one more time what you need us to know about the kidneys and the adrenals?
Yeah. So I think it's important to me that you know that, number one, the kidneys have what we call juxtaglomerular cells that sense the increase or decrease in blood pressure. Okay. It's important that you know angiotensin starts in the liver, goes to the lungs, goes to the arteries where you see vasodilation. Okay. It's important to know that aldosterone, the more aldosterone you secrete, the more you're going to pee to decrease your volume of fluid in your body. Because the more excess volume, and when we say volume, we're talking about blood, serum, water, all the components of our extracellular fluid is what I mean when I say volume. Okay. If you have an increased amount of volume in your cardiovascular space, your veins, arteries, your blood pressure is going to be high. If you have a decrease like hypovolemia, where you're very low in that volume, you're going to see hypotension. Okay? So the more volume you have, the harder your heart has to work to pump and the higher your blood pressure is going to be. Make sense? Okay.
So would hypo go through the same phases to get it up?
Hypo? I'm sorry. So hypo, when you're hypotensive, because technically we're only talking about antihypertensives, but when you're hypotensive, your body is going to try to counteract and vasoconstrict so that the blood pressure can go up. And it's going to try to hold on to fluid, hold on to sodium, okay, so that it goes up. Okay, so we talked about ACE inhibitors. What do my ACE inhibitors end in? Pro.
Pro.
What do my ARBs end in?
Sartan.
What is a really good example, most well-known example of an ACE inhibitor?
Lisinopril.
Lisinopril. What is the most common ARB?
Losartan.
Losartan and valsartan. They're both really common. Okay. So now we talk about calcium channel blockers. Okay. So potassium and calcium are extremely important ions for your heart, for your cardiac function. Okay. And sodium can have some, but potassium and calcium are going to be your highest ions that are major players when we talk about cardiac function. So calcium channel blockers, the mechanism of action is that it blocks the calcium influx, which then relaxes the smooth muscle of the cardiac muscle. Okay. This decreases the blood pressure and the workload of the heart. Excuse me. So we have two different types of calcium channel blockers. And I told you there was two different types. We have the dihydropyridines, which is most of your calcium channel blockers, and the suffix is dipine. So this is your amlodipine, okay, or Norvasc. But the NCLEX tests on generic names, not brand names. Okay. So we have to really try to make sure we're learning our generic names. Okay. So our dihydropyridine calcium channel blockers end in dipine, like amlodipine. Another calcium channel blocker that is common is nifedipine. The primary use for these is hypertension because it causes vasodilation. When we have vasodilation, the blood pressure goes down. Okay. There is a risk with nifedipine that it can cause rapid hypotension. So you want to be careful with nifedipine use. It's not a super common calcium channel blocker. What it can do, and this is important, is that all calcium channel blockers are contraindicated in pregnancy, except for nifedipine. Nifedipine can be used for hypertension in pregnancy. So then we have the non-dihydropyridines, my zebras. These are my favorite drugs to quiz you on. Wink, wink, wink. These are my favorite drugs. Okay? So these drugs are diltiazem and verapamil. They don't end in dipine. No, they don't. But they're still calcium channel blockers. And remember, these work on hypertension. These work on arrhythmias. Okay? So diltiazem and verapamil slow the conduction velocity at the AV node. Remember, when we talked about cardiac conduction, the SA node is our pacemaker. It sets the rhythm. 1, 2, 3, 4, 5, 6, 7, 8, all the way 60 to 100, right? Beats per minute. My AV node is where I got to chill for a second because my chambers can't all relax at the same time and they can't all contract at the same time. So while my atria contract, my AV node allows my ventricles to relax so that they can fill. Okay? So if this is happening, oh, it already says it. The indication, I was going to try to quiz you a little bit, but it already says it. The indication would be for atrial fibrillation with RVR, which means rapid ventricular response. So that means it's an AFib rhythm, atrial fibrillation rhythm, that's greater than 100 beats per minute. Okay. RVR, rapid ventricular response, is AFib that is greater than 100. So it slows the atrial conduction. Because what happens in AFib? Do we know? So the atria are supposed to go boom, 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 right? Well, in AFib, my atria are going like this. They're like seizing. They like can't control themselves, okay? And there's just, it's all willy-nilly. All right? So, and it's because my conduction system between my SA and my AV node is all jacked up. Getting all crazy. It's acting out of line. Like somebody shocked it or something. Okay? And we need to be like, hey, you need to calm down, bro. Like you need to like chill. Because what happens with AFib when your atria are going crazy is that blood pools. And what happens when blood stays in one place? It clots. Which is why it is extremely important that anybody that has an atrial arrhythmia like AFib or AFlutter is on an anticoagulant for the rest of their days. Okay? Because the more that your atria fibrillate or flutter, the more at risk you are for clots that will lead to DVT, PE, or an MI. Okay? A very important thing is at the bottom of this screen. Dietary warning. No grapefruit juice. You are going to see grapefruit juice as a contraindication for so many things. Like, I don't even know why they even make grapefruit juice anymore. It's contraindicated with like so many drugs, it's disgusting. Girl, you better not have hypertension. So, zebra. Next, we're going to talk about a classification of drug called cardiac glycosides. The most common cardiac glycoside is called digoxin. Digoxin is a very special drug. It is a positive inotrope, which all that means is that it makes the heart contract harder. Okay? It gives the muscle a little oomph. So if you're in heart failure, if that muscle isn't contracting hard enough for your cardiac output, digoxin can help increase that cardiac output by strengthening the contraction. Okay? It's also a negative chronotope, which means it slows the conduction. So it works with not only a lower cardiac output to help the contractility, it's also an antiarrhythmic that slows the conduction system.
So it pumps harder, but slower.
It pumps hard. Think about harder, but more effective. So write that down. Harder / more effective. Because sometimes harder isn't always the greatest thing, right? Because that can lead to a whole slew of problems. But when you pump harder and more effectively, then that's going to make your cardiac output better. Okay? The reason that digoxin is such a big deal and is a huge, big ticket item on your NCLEX is because it has a very small therapeutic range. So have you learned about lithium? Have you learned about digoxin at all? Have you heard or learned about drugs that have a small therapeutic window? No. Beautiful. I love that for me. Okay. So what that means, okay, we're all in some type of healthcare situation. Maybe you've seen or known someone that takes Coumadin or warfarin. Okay. You know that if your patient has an INR greater than 3, then that means it's too high and your patient is too anticoagulated, right? The warfarin dose is too high. Okay. It's the same idea. It's all about the therapeutic range. So for Coumadin, your therapeutic range is between 2 and 3 because that means the patient is adequately anticoagulated, right? If it's less than 2, we need to increase the dose. If it's more than 3, we need to lower the dose or hold it, okay? So when we talk about a therapeutic range, it's the same idea with any of the drugs. It just means that you need enough to get you over 0.5, but you can't take too much that's going to put you over 2. And the thing is that it's very small. It's only 1.5. Very, very teeny tiny. So there's no real big room for mistakes. Okay. So what is digoxin? What do you need for digoxin for it to be therapeutic? Well, digoxin binds to your extracellular potassium. This is very important. I need you to listen to my words. Digoxin binds to your extracellular potassium. Okay. If you are hypokalemic, your potassium is 3. Okay. And you take digoxin. Your digoxin is going to bind to your available extracellular potassium, okay? But there's not enough potassium. So that means there's free floating digoxin that's not binded to anything, just floating around. And guess what causes? That causes your therapeutic range to be that causes your serum of digoxin to be out of range. Okay? So I need a buddy. I'm digoxin. I need a buddy to work effectively. My buddy is potassium. Okay? Potassium, we're walking together and we do our job together. We need each other. Okay? But I got a digoxin over there with no buddy and he's acting a fool. Nobody's keeping him in check because he doesn't have his buddy. And he's going to make me toxic. Okay, so hypokalemia significantly increases your risk of digoxin toxicity because there's no buddy. That makes sense? Okay. So, huh? I told you, this is literally my goal in life is to help you understand everything. I have my moments. When we get to antibiotics, I'm not going to be able to pronounce nothing. Okay, so we have a narrow window of 0.5 to 2.0. By the way, what is this called? 0.0? What do we call that? Why is this wrong?
Because there is no 0.0.
There is no 0.0. That is called a trailing zero. That is called a trailing zero. That is wrong. Do not answer any of your questions on your math test with a trailing zero, please. Please and thank you.
Saying I'm Googling one of the students says
Who? NG equals no. Octavia, you are just one smart little cookie, girlfriend. Listen, I don't know. It's the way that it's measured in the blood. And I love that your brain is sciencey. Love that for us. She's like, okay. But yes, I think so. Like when it says DL, I'm pretty sure that means deciliter. I have no clue. Okay. I just know that this is my labs and this is what it says on the computer. Okay. When it comes back from the lab. So my zebra, when it comes to the signs of toxicity, this is very important, is visual disturbances. It looks like to the patient, yellow, green halos around the lights. So if you were to look up at the light and you had digoxin toxicity, it would look like it had yellow and green halos around it. Okay. Number one, zebra for digoxin toxicity is yellow-green halos, visual disturbances. I don't care if it doesn't say yellow-green halos. If it says visual disturbances, that is also the answer. Okay. Toxicity symptoms other than our zebra include anorexia, nausea, vomiting. By the way, there's a difference between anorexia and anorexia nervosa. Okay. Anorexia nervosa is an eating disorder. This is when a person stops eating to lose weight. Anorexia in medical terms means that you do not have an appetite and you don't want to eat because you don't have an appetite. Your body says, I don't want that. It's like you took too much semaglutide, too much Ozempic, okay? And you don't want to eat, okay? The antidote to digoxin toxicity is called DigiMune-Fab. It is also called DigiBind, okay? DigiFab. I need you to know that.
These two or the first one you said?
All three of them.
Can you spell that first one?
DigiMune-Fab is just D-I-G and then immune, I-M-M-U-N-E, fab. DigiMune-Fab.
Oh.
Okay, DigiFab, D-I-G-I-F-A-B. DigiBind, because why do I need to bind to it? Because they have no buddy. So my antidote of DigiBind, they all work the same way, by the way. DigiFab, DigiBind, DigiMune-Fab, they all work by binding to the excess digoxin. That's a great question. I have no idea.
Oh.
I actually have no idea what it's made of, but that's a really good question. She said, what is it made of? Potassium? Fair. That
If
is
you
fair.
question us on this for the exam, which one will you use?
Well, first of all, oh, you mean antidote? Girl,
Yeah.
Get out of here.
I'm just
Go all
asking.
three
I
of them.
wasn't sure.
All right. Important nursing action. Because it slows the conduction. You cannot give this drug if your apical pulse is less than 60 beats per minute. Which, by the way, where on the chest do you listen to an apical pulse?
The fifth left intercostal.
Okay. Fifth mid-clavicular intercostal space,
That's under the blue.
right?
Right up under, lift it up. Sometimes you gotta look at the.
I already had mine lifted, so. So, in the NCLEX world, we hold if the heart rate is less than 60. In the real world, we call the cardiologist and say, hey, your patient's heart rate is 57. Do you want me to give the digoxin or hold it? Okay. In the NCLEX world, we hold it. Okay. We don't have a lot of time. We're done at 2, right? Is it 2:30? Oh, thank God. I thought it was 2. It legit is 2:30? Okay, good. Okay. I hate running out of time. Have you guys discussed heart failure?
Yeah.
So you know there's a difference between right-sided heart failure and left-sided heart failure, okay? What part of the heart is failing in heart failure?
The ventricle.
The ventricles. If I have hypertrophy, what does that mean?
Far at large, stiff and left side, right? Large part.
I didn't want you to include stiffened. So hypertrophy is just like whenever you overwork any muscle in your body, the muscle grows, right? So hypertrophy is when the muscle gets larger because our heart truly is just a muscle, right? So if you have right-sided heart failure, you're going to see right ventricular hypertrophy. If you have left-sided heart failure, you're going to see left-sided hypertrophy, okay? When you have right-sided heart failure, what are your symptoms?
Peripheral edema.
Peripheral edema. This is what I do. You better get used to it. She said, ugh.
It's the rest of the
Well,
body.
right, that's what I'm.
Okay. Rest of the body, what does that mean? Where? I have peripheral edema. What else? What do I see?
Oh, jugular vein.
JVD, jugular venous distension. What else can I see? Ascites. Okay. Okay. When I have left-sided heart failure, what do I see? Pulmonary edema / congestion. They can be referred to in the same way. They mean the same thing. Pulmonary edema, pulmonary congestion. They both mean that there's fluid in the lungs. Okay. What do I hear?
Crackles.
Crackles. Bronchi. Okay. What happens when my left-sided heart failure gets so bad?
You get weeping.
So bad that my
You get
cardiac
right-sided heart failure.
output- What is it? Say it.
Then you get right-sided heart failure.
Yes, baby.
That's all I'm about to say.
Right? So if your left side is failing, Brandy, I know that she's not in here. Brandy and I are in very similar situations. Brandy Bresman, Mrs. Bresman, who is my code teacher, is the ADON of the Sylvania campus. And she is going through a very similar situation with a family member that I am. Sucks that it's happening at the same time, by the way. But Brandy was a heart failure educator for a long time for patients on the floor. And I really liked the way that she described it. It was like a car pileup. So if your car is piling up, you have an accident in the right ventricle and it's piling up and everything is backed up behind it. It's the rest of the body, right? So your pileup is going out the right side to the rest of the periphery. If the left side is backing up, your pileup is happening here. What's behind? First of all, what's behind the left ventricle? What pumps into the left ventricle?
Left atrium.
The left atrium. And then what's behind the left atrium? No. Where does the blood come from when it's going into the left atrium?
Pulmonary vein.
The pulmonary vein, which is coming from the lungs, which is why our backup is going into the lungs because it's piling up. So then my left-sided heart failure is so bad, I'm in bumper to bumper traffic all the way 3 miles away. It done backed up from my pulmonary vein through my lung capillary system, back into my pulmonary artery, done backed up into my right ventricle, backed up into my right atrium, and then done backed up into the rest of my body. Okay, make sense? Okay, so there's a couple ways that we treat heart failure. We're going to talk about diuretics next week, where we decrease the volume of fluid, right? But we also have drugs like Entresto, that is a combination drug with valsartan and sacubitril. And it breaks down the natriuretic, which we call the N peptides, like NP peptides, and blocks the RAS system. So it blocks renin, it blocks aldosterone, it blocks angiotensin, okay? And it results in decreased vascular volume. So we're peeing more, the volume is getting lower, and cardiac workload. If we decrease the volume, then we automatically decrease the workload. That makes sense? A little bit? Okay. So then we have, my phone is blowing up. HCN channel blockers. I am not going to test you on this. This is a good to know, not a need to know. But it does have its own zebra to not use if the patient is bradycardic. Most of the time, you're going to hear me say this a lot. In nursing, in medicine, you're never going to say never, and you're never going to say always. There is always a variable. There is always going to be someone that is outside of the norm. Okay? So, most of the time, 9 times out of 10, you are not going to use cardiac drugs with a bradycardic patient. Let me specify, a cardiac drug that's going to lower your rate. Okay. So I would use this. Why am I leaving? I want to leave. Something just came out. It said, are you sure you want to leave this site? No, I don't. I don't. So you should use this as a rule for NCLEX specifically, that you don't want to give drugs that are going to lower your heart rate if your patient has a heart rate less than 60. Okay. What if it's 60? What if it's 60? I'm calling the provider. Because we're borderline, right? Are we 60, 59, 58, 61, 57, 60, right? I'm calling the provider. I'm calling the cardiologist to make sure that they're okay. Because guess what? These drugs for rate control, they're given to patients with arrhythmias that have a history of AFib, A-flutter, SVT, VTAC, which we're going to talk about all of those in a couple months, right? If you hold that medication, guess what you just put your patient at risk for? Arrhythmias. And you know what really sucks is when you call the cardiologist and you say, hey, bro, I held this patient's metoprolol this morning because they had a rate of 61 and I used my nursing judgment, which, by the way, great, but now they're back at AFib. And that provider is going to be pissed because we work hard to keep our patients out of arrhythmias. Okay? So cover your ass, call your provider and say, hey, my patient's borderline bradycardic, or my patient has a heart rate of 50. What do you want me to do? Especially if you don't have parameters in your MAR. Okay?
Just a quick side note, we have a patient at the facility I work at.
What type of facility do you work
Long-term care.
Okay.
So she's like late 60s. She's a younger patient. She's overweight, just can't take care of herself. So she's a history of AFib. Her blood pressure runs like 90s over 50s, normal. Her heart rate's like 118 because of her AFib. And nurses that don't understand that metoprolol 4 or 8 will hold it because her pressure's low. Even when we give it, she goes to like 80 over 45. Like it doesn't affect her pressure. So they put parameters in like if it's 60 over 30, hold it. Like the weirdest parameters ever because nurses keep
Because they
telling her
wanna-
she's thrown.
So she's saying that I've learned over time that my onlineians have a really hard time with side conversations that we have in the classroom. So when we have a conversation on the side, I will usually repeat our conversation to my friends online so they don't get lost. So she's saying that she has a patient at her facility, it's a long-term care facility, who is naturally hypotensive with a pressure of like 90 over 60s or whatever. But her heart rate is higher. She has a history of AFib and she's running at like over 100 with her rate. And nurses that aren't maybe new to the facility or just don't know the patient or just don't know that they should call a provider are holding the metoprolol. And because they're worried about the blood pressure, because valid. I mean, the patient is hypotensive. So it's a valid thing to think about. So the long-term care providers are so sick of this patient going in and out of AFib, I'm guessing, because they keep putting her back in AFib for holding it, that they put in parameters that they shouldn't hold the metoprolol unless her pressure is like super, super low. So you can't see that. Is everybody okay to keep going or do you need a break? Everybody okay? Okay. I mean, you guys are lucky at home. You can like go get a beverage and like pee. If you need to step out, please go. Okay. All right. So then we have rhythm control, which now we're really talking about antiarrhythmics. Okay. We have what's called sodium channel blockers, which is our class 1 antiarrhythmics. Sodium channel blockers are not very common. Sodium and potassium have a very, very fine, delicate balance, and we really don't like to mess with it. So I think sodium channel blockers are not super common for that reason, because it can really disrupt our sodium potassium electrolytes. So, but one of our sodium channel blockers is IV lidocaine. And you think, well, Jess, lidocaine is for my tattoo that I just got, and I use lidocaine cream so I could sit through my tattoo. I'm not talking about lidocaine that you put topical. I'm not talking about lidocaine that you get at the dentist. I'm not talking about lidocaine that they inject into your subcutaneous tissue. I am talking about, it is the same thing. It's lidocaine. Lidocaine is lidocaine. But when you inject it IV, it can help with ventricular arrhythmias. And lidocaine is used specifically in a very, very controlled environment in the OR, in the cardiac cath lab, in a cardiovascular intensive care. It's not just given all willy-nilly on the floor. Okay. You're probably not going to see this given unless you're in a specialty area. But your zebra for lidocaine is the central nervous system effects. It can cause confusion and drowsiness. The thing about lidocaine is that you can quickly have toxicity with lidocaine. When you inject it into the subcu tissue, it takes longer to absorb into the body. You can still have lidocaine toxicity, and really any injectable numbing agent, you can have toxicity, but the way that it's absorbed into the body is slower and it takes longer and it takes more of the drug. When you inject it right into your veins, it can make people go cray cray, and it's dangerous. Okay. Class 3 potassium, or I'm sorry, class 3 antiarrhythmics include potassium channel blockers. These are definitely going to be more common than your sodium channel blockers. Sodium is much more delicate than potassium. Okay. And our example includes amiodarone. Fun fact, I had such a hard time pronouncing this word in nursing school, and I could not figure it out for the life of me until one of the girls that I went to school with was a pharmacy tech, and she said it's amiodarone. So then that whole day I'm like, amiodarone, amiodarone, trying to get it to stick in my brain. So amiodarone can be used in life-threatening ventricular arrhythmias. It is used in ACLS when we have VTach or VFib. But it's also used as an antiarrhythmic for patients with AFib. Okay.
So this says,
Say it again.
so is B the ventricle and AFib is the atrial?
Uh-huh. So when we say AFib, we're talking about the fibrillation of the atria, which, by the way, you're alive. VFib, which is the fibrillation of the ventricle, equals dead.
Okay, I think I really enjoy.
VFib equals defib, as in defibrillation, dead. Can't get deader. Okay? Yes. Yes. So, our zebras with amiodarone include pulmonary toxicity, which can lead to fibrosis. I've never seen that. This is a very controlled situation. So you can have PO amiodarone, where people are on like 200 milligrams once a day, BID. It's PO, it's by mouth, and they're on this long-term for antiarrhythmias, which it's probably for AFib, A-flutter, okay? When we're talking about life-threatening conditions like pulseless ventricular tachycardia or ventricular fibrillation, with, by the way, both are dead because both are pulseless, that is when it's slammed and it's given IV. We can give amiodarone as a bolus to kind of break someone out of AFib, but it's in a much smaller dose, much more controlled than slamming a dead person with amiodarone. Okay? So two different uses, but the point is that it is for arrhythmias, can be life-threatening, or just a regular old AFib. Okay? To help control the arrhythmias. You can see hepatotoxicity, which means if I have cirrhosis, if I have liver failure, if I have high LFTs, liver function testing, and I don't have a great liver, I may not want to take amiodarone. Okay? Thyroid dysfunction. So if I have a non-functioning thyroid, that probably wouldn't be a great thing. And then we also have something called blue-gray skin discoloration. Never seen it in my life. Definitely a zebra. Very, very uncommon. Not testing on that. Okay.
Not testing on skin color.
No. And again, no grapefruit juice. So no amiodarone for you. I forget your name already. Chardonnay. Yes. Oh, damn it. No, Ashanti's over there. Don't tell me. I'm gonna get it. Candace. Listen, me and Candy over here had some words a couple months ago. She was mad at me. Okay? She was mad at me. All right. And I was like, I wonder how these girls are gonna be receptive towards me because they don't like me. No, it's okay. It's okay. That was like the most stressful weekend of my life. Of like work specifically. I was so panicked.
I feel like you were thrown into a lose-lose situation.
I 100% was thrown into a lose-lose situation. But that we're gonna lose them if we keep going on sidetracks. But we'll talk about that at some other time. So next is our fun beta blockers. Super common medications. Beta blockers end in olol. Our most common beta blockers would be metoprolol, for sure would be your number one. Atenolol is, you see it, not super common. Propranolol, you will actually see more in younger people because they use it for anxiety. They can use, propranolol has a, what's it called? Like an off-label use for anxiety. Is it like? People do use it as a PRN because usually when you have anxiety, your heart's racing. And when you have like really physical anxiety and your heart's racing and that makes you even more anxious, the propranolol will actually slow down your heart rate, which will lessen your anxiety because it's not as physical. And I think it does something else, but I don't know. So the mechanism of action is that it blocks the sympathetic nervous system stimulation. So your fight or flight tachycardia, okay, slows the heart rate and a little bit decreases the blood pressure. Just a little bit, not a lot, just a little bit. Okay. If you have someone that is only hypertensive, I would be surprised if their only drug that they're on is metoprolol. Okay. Metoprolol is not going to be your number one gold standard antihypertensive because it only works on the blood pressure a little bit. Okay. So zebra alert, very important. Very important. So have you heard of beta 1, beta 2? Okay. So a quick little memory thing is you have beta 1, you have one heart. Beta 2, you have two lungs. Okay. So beta 1 works on the cardiac tissue. Beta 2 works on the lung tissue. Okay. Now, you have what's called selective beta blockers that are mostly beta 1. But then you have non-selective beta blockers that can work on both beta 1 and beta 2. Okay? Which is why patients that have a history of asthma and COPD, which are restrictive airway diseases, should not take beta blockers because it will cause bronchoconstriction. Because not only is it working on beta 1, one heart, it's working on beta 2, two lungs. So if you see a question, wink, wink, in the future, where you have a patient that was recently prescribed metoprolol, and he has a history of COPD, and he's coming in and saying, yeah, I just feel more short of breath, and he's coughing, and maybe you just hear, it doesn't sound great. He's more symptomatic of his lung disease. The patient needs to be given a different drug. You get what I'm putting down?
Yep. So why would they give them that in the first place if they do have like?
Great question. Why would they give it if the patient has a history of COPD and asthma? I'm not a doctor. I don't know. Why do they do these things? I don't know. I don't get paid enough to know. I get paid enough, and my license depends on me using my critical thinking skills to say, hey, Mr. Doctor, Mrs. Doctor, your patient's symptomatic of COPD exacerbation, and he's not tolerating metoprolol, so maybe we should change that. Okay. Another huge, just put a star on this page, like the whole page.
No.
Another huge zebra for beta blockers is that they can mask the symptoms of hypoglycemia. So your patient has a blood sugar of 32, but they're not symptomatic. And now they're dead because nobody tested their blood sugar. And now they're in a hypoglycemic coma and they died. Okay. It is very important to know that beta blockers mask symptoms of hypoglycemia, including tremors, palpitations. Nursing action, monitor blood glucose closely. Black box warning. Do not ever stop your beta blockers abruptly. By the way, unless you are directed by a physician, sorry, I got something on my lip. Do not ever stop medication abruptly. Ever. I don't care what it is. Okay? My Lexapro girlies, you stop your Lexapro cold turkey, you're going to get brain zaps. Like inside your brain. It's the weirdest, craziest feeling and it's horrible. Okay? You stop your beta blocker abruptly, you're going to have what's called rebound hypertension, which means you had controlled hypertension and now you stopped it abruptly and then boom, you're 190 over 110 and you're in a hypertensive crisis. Yeah. Correct. Hold on one second. So she's asking if the metoprolol
I have a
doesn't work
question, Ms.
very well
Simmons.
on blood pressure regulation, decrease,
Okay, sorry.
why, right? Why would it cause rebound hypertension? Or yeah, hypertension.
Right.
That's a very sciencey answer. And is that it's a huge risk for if you stop it abruptly. So did you ever hear about like rebound congestion? When you use a anti-congestion, or if you've ever used Afrin. God, Afrin is God's gift to earth. If you've ever had pregnancy rhinitis and you can't breathe and you can't take a decongestant because you're pregnant, the only thing you can use is Afrin. I got Afrin in my purse. I got Afrin at home. I got Afrin in my car, but you can't take it for more than 3 days because if you do, your body gets dependent on it and you have rebound congestion.
So I guess what I'm asking is if you don't have hypertension or like using metoprolol not for hypertension,
You would still be at risk.
okay, that was my question. Your body's kind of like
It becomes dependent.
shock, basically.
Yeah,
and
it's the abrupt withdrawal of the drug that's going to cause the rebound hypertension / MI.
Wait, so when you take
Yeah, we're gonna
Afrin,
some-
when you take Afrin, you get hypertension from it if you take it too long?
No,
I was
no,
gonna say,
I
use
was
that,
talking
like,
about rebound congestion with Afrin.
Oh, okay.
It's
I
the
was
same
like,
idea when you have a rebound side effect.
okay, I was gonna say I love Afrin, and I know you're supposed to only
I
use it
love
every 3
Afrin,
days.
girl.
Oh my gosh, I have it everywhere. My job
I
actually gave
know.
me it from Costco because I
And it's
used it so
because you
much.
just had a baby, isn't it? You had pregnancy rhinitis, didn't you?
Even just in general, it got worse when I was
She said
pregnant. but I
even just in general.
I love Afrin. Someone showed me Afrin, and I'm like, I will never go to anything
love
ever
Afrin.
again.
Bertoni, what were you gonna say? Bertani, am I saying that wrong? I feel like I'm saying it wrong. Oh, I love that. Thank you. Bree.
Just call me Bree. It's a lot easier. Oh,
Yeah.
So the question is in regards to the metoprolol
You can't,
and all
yes,
the other laws.
yes.
If
You would,
never
yes,
had
because no
hypertension
matter what,
before
if you
or blood
stop
pressure
this
issues,
drug
so they gave you that
abruptly,
for the
whether you
tachycardia.
have a
If you
comorbidity of
stop it abruptly, would
hypertension
you become
at all,
hypertensive
you would
afterwards?
still
even though
be
you
at
had no-
risk for
Huh.
rebound hypertension. Ah, she said I stopped this.
I have two, that's why I was asking.
I have a
I
question.
can't
Melanie,
stand
nurses
you.
are the worst
I've stopped those,
patients.
medications
ahead.
abruptly like 5 times. So that
With
will explain
the
a whole bunch.
propranolol, you
Thank
said
you.
it could be PRN. So is that meaning like if you don't take it consecutively, consistently, you're able to take it when you need it then? Without
So
it causing those issues?
that is
or does that work?
specific. That is specific to propranolol, not for beta blockers in general. It is very specific to propranolol when we're talking about anti-anxiety. And I don't know if you were to take I don't think when you take it for anxiety, I don't think it's meant to be taken every day, because if you are taking an anti-anxiety medication every day, you should be on an anti-anxiety med every day. You know what I mean? So if you are taking propranolol every day for anxiety and you abruptly stop it, you probably would be at risk for rebound hypertension. Yeah. Yep. Does somebody have another question? I thought I saw somebody else.
I was laughing at Bertani.
Oh,
Saying nurses make the worst patients.
they do. They do 100%. Oh, one of the scariest drugs ever created is called adenosine. Adenosine makes me clench my butt because I get it. It's just oof. So, see this picture here? Okay. This, my friends, is called SVT. Adenosine is the treatment for SVT. SVT is supraventricular tachycardia. Okay. It is not sustainable. Okay. So can you be an SVT for like an hour? Sure. For like a day? Ugh. Probably not. Because in SVT, you have a rate between 151 and 200. Okay. And it's not a great place to be in. Okay. So the first thing we do for SVT is called a vagal maneuver. And that's when you bear down or you cough or you blow through a straw, something that's going to trigger your vagus nerve. Because when you trigger your vagus nerve, your heart rate can drop. Okay. That's why people like Elvis died on the toilet. Not only was he constipated for like a month, he also vasovagaled so bad when he was trying to poop that he literally stopped his heart from triggering his vagus nerve. Okay. So your vagal maneuver, we have a beautiful, scary drug called adenosine. There is something very special about adenosine, is that it has to be given as fast as possible. And the reason being is because it has a very short half-life. Do you know what half-life means? So I love the honesty because I would rather explain it than not. And I was going to explain it anyways. So half-life. So a drug stays in your system for, let's say, 2 hours. I'm just making something up. The half-life of that drug is 1 hour. So that means in 1 hour, there's half the amount of drug left circulating in your body. So when I say adenosine has a very short half-life, I'm talking seconds, literal seconds. So if you were to slowly push adenosine, by the time it actually got to your heart, it don't work anymore. Okay? So adenosine is meant to be pushed as fast as possible, followed by a saline push as fast as possible. Okay? And what happens is this SVT all of a sudden goes boom, boom.
It resets, it literally resets.
Boom, 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 boom. Okay. The point of adenosine is that it stops the electrical conduction of the heart, and then your heart restarts in a normal sinus rhythm. That's the goal. Okay.
That's scary.
It is horrifying when you see it in real life. Huh? No, we push that.
Yeah.
Nurses push that. Oh, yeah. What'd you say? I can't hear you. No, I think it's my laptop.
Hey,
Like,
Miss
it's like not
Simmons.
very loud. I think I'm gonna have to switch to my other one, but go ahead.
Hey, Miss Simmons. Oh, can you hear me now? I'm sorry.
Do you?
Well, that sucks. I have an
She sent me
Echo,
have you
one
ever
of
had
the
a
Echo
adenosine?
stethoscopes, and I also have SVT. I showed my boss my heart. Yeah, when I was in SVT, I showed my boss the rhythm
And
on
she's
my
just
phone, and she
abruptly
sent me home.
stops her metoprolol.
So,
I'm gonna, ooh,
I think when I was
girl,
13, because I was in
I'm
SVT for
mad
like
now.
10 minutes, but
Really fast ways to
many
piss off a
times.
nurse. Don't finish your
That's
antibiotics
fine.
and stop your cardiac
But
drugs
yeah,
abruptly. That's a really quick way to piss off a nurse. So Bree, when you if you remember, I mean, obviously you were if you were 13, that was a long time ago. But I have had patients that say that when they get adenosine, it feels like they got hit by a bus. Like it literally feels like somebody slammed into their chest because your heart literally stops. And what's crazy is the look on their face.
oh yeah, it was complete
Like the
garbage.
look on your patient's face is
It was
so
complete trash.
normally
It was
you're going to see an
bad.
asystolic line here, asystole, for anywhere between 2 to 6 seconds. Now, I want you to think about when you see someone without a heartbeat for 6 seconds, how long that feels like. Because it feels like 10 minutes because you're literally just standing there like, oh my God, is it gonna start again? Okay. So, what do you think is one of the most important things when you give adenosine?
Crash cart.
The patient will absolutely be attached to a defibrillator, yes. But, okay, maybe I shouldn't have said most important. What do you think is like super valid that you should do for your patient?
Tell them what they're gonna.
Tell them. Tell them what's going to happen to them. Okay? Hey, you're an SVT with a rate of 186. I'm going to give you this drug, and it is going to feel like somebody punched you in the chest as hard as possible. Okay? Like a big UFC dude just like slammed you in the chest.
You tell them it's gonna pause there.
Yes, your heart is going to stop, my friend. And literally, when it happens, you're a computer malfunction. Like they're sitting there and and it looks like somebody just like hit pause. I'm not kidding. It's freaking weird. It is weird and it makes me very uncomfortable and I hate it. When you give adenosine, your patient should be attached to a defibrillator. Because what happens if your patient does not come back, or if they come back in VFib, or they come back in pulseless VTAC? We need to, if they stay in asystole, we need to start CPR. If they go into VFib or pulseless VTAC, we need to defibrillate and start CPR.
The difference between VTAC and
VFib is a line that goes like this, and VTAC is a line that goes whoo, 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 whoo.
both equal dead.
Both, well, don't get ahead of yourself because you can have pulsed VTAC or you can have pulseless VTAC. So pulseless equals dead. VFib equals dead. Pulsed VTAC is not dead yet. Because if you don't get your patient out of sustained VTAC, the patient can't sustain and they will end up arresting because the heart just can't take that rapid of a movement and that type of arrhythmia for a long time. But I love where your heads are going though. But unfortunately, we're not getting into makes me really excited to see you in 2 months. 3 months. Okay, so rapid IV push, very important to know, 1 to 2 seconds. Follow with immediate saline flush, very important to know. The reason, the half-life is less than 10 seconds, important to know. Okay? The patient experience, they have momentary asystole, which is very scary when you see it in person. Warning, patient may feel kick in the chest, pressure, or a sense of impending doom. Impending doom is very serious and it is so real. Like, yes, do you have your like old people that are like, I'm gonna die? Yes, yes. If you work in a nursing home, if you work in long-term care, if you work in the hospital with a bunch of old people, then yes, you have seen your old people that are like, I'm gonna die, okay? But when you have a patient look at you and say, something is wrong with me, I am going to die, that is called a sense of impending doom, and it is real. Specifically with arrhythmias, specifically in OB, when a laboring mom looks at you with this intense fear of I'm going to die, your patient may cardiac arrest right in front of you. It's called an amniotic fluid embolism, and it's one of the scariest things that can happen in labor and delivery. So when you hear that, and we're going to talk about that a lot, not a lot, but we're going to talk about it in critical care, it is very real. And you should not ignore that sense of impending doom. Okay. Nursing note, have a crash cart nearby. You really should already have your patient with the pads on when you push adenosine.
It's the whole point of the saline push after, just to ensure all the adenosine gets there as quick as possible.
Yes.
Make sure that it's not.
She said it is the whole point of the saline push to make sure the adenosine gets to where it's going, yes. Because it has a very short half-life and you want to make sure it gets there as fast as possible. So have you ever seen a three-way clock stop?
Okay, that's one more. Like, how do you-
So the worst way to do it is to have two syringes, one with adenosine and one with saline, push the adenosine and then fumble with your saline to get it on and then push it, right? That's the worst way to do it. Worst way to push adenosine. The best way to push adenosine is to have what's called a three-way cock stop, which means it has a port here and it has a port coming out this side and a port coming out this side. Okay, and it has a little nozzle thingy that you turn, and when you turn it, you turn off one of your valves. So each opening has a valve, right? So if you turn it all the way this way, all three of my valves are open. Okay, so I have one valve connected to my patient. I have adenosine on this valve, and I have a saline flush on this valve. Okay. And I'm turned off to my patient. So when I give adenosine, I am going to turn it off to my saline flush. I am going to push my adenosine, flip my cock stop, push my saline. You could also open all three and have your nozzle going down. So all three are open. And you push your adenosine while you're holding your syringe in, push your saline. Because if you don't hold your adenosine in, your saline could go into the adenosine syringe. So if you're going to do it that way, you have to be smart about it. Okay. But it's the best, fastest way to give adenosine. Okay.
One last question.
Yeah.
Is this like everybody in the room type situation?
Oh yeah.
Or
She said, is this like everybody's in the room situation? Yes. You have a provider standing at the bedside. You have multiple nurses. And respiratory may just be hanging out outside the door. Okay. Okay. Ischemia management and anti-anginals. What is angina? Chest pain. We have a couple different types of chest pain, which we're going to talk about. But when we talk about vasodilation and angina, the most common medication is going to be nitroglycerin. Nitroglycerin causes massive vasodilation. Okay. So how it happens is that the potent vasodilation affects the veins and the arteries. Okay. So it just vasodilates everything. Because the reason you're having chest pain is because of the narrowing of the arteries in the coronary arteries in your heart. Okay. The one thing that I want you to remember about the heart muscle itself is that it has its own circulation. There is no other muscle in the body that has its own arterial blood supply. Your heart has coronary arteries that wrap around both sides of the heart to provide its own oxygen supply. So when you have an MI, a myocardial infarction, that is when one of those coronary arteries that are on the heart muscle itself gets blocked and causes hypoxia to that tissue, to that muscle tissue of the heart. That's what an MI is. Okay. So when you have nitroglycerin, it vasodilates the arteries, including the coronary arteries. But you can't say, oh, I only want the coronary arteries, right? Because remember, those receptor sites are everywhere. Your arteries are all throughout the body. Okay. So when you take a drug that's going to go to those receptor sites, it's not only going to the receptor sites in your coronary arteries, it's going to your receptor sites throughout the entire body. Who is that? Is it Christy? What? What? She yells at me every day for bringing drinks in the classroom.
I was just gonna say, should we tell her there's no drinks allowed in here?
Oh my God, is that sweet? What'd you say? Oh shit. Yes. We have to do that right now. Right now.
Are we
I'll be
still
right
going to
back.
go through
I gotta
math?
get my camera. Actually, no. I'm gonna do it.
Are we
with
still
this.
going to do math?
I lied. All right, we're stopping here. Okay. Thank you.
You'll go through the rest of this on Thursday?
Yeah.
Okay.
Yeah, we're gonna finish this content on Thursday.
Is there new content Thursday or is it just?
No, it's all cardiac. Thursday is all cardiac. We might get into renal. If we can, that would be great. If we don't, it's okay. Yeah, let me do that right now.
There's only one bar.
No. Okay. All right, so the RAS pictures I just put on Brightspace. Practice what? Yes, your practice A is due on the 8th, your practice B is due on the 15th. Yes.
same day.
Girl, I can only do what the hospitals let me do. No, I have not.
No, I'm just curious.
Are they good or bad? I've heard that about Almond. I love UH Portage. Don't be coming at me like that, girl. She said, I'm poor and I need to work that day.
I mean, I can say, I did, I think about it. Because my Sunday would be, y'all, I left my class on Monday.
This is the first time I've ever had class Tuesday, Thursday. I like it. I like it. I usually have class Monday, Wednesday. Okay, so because the pharmacology math is like, it's like an overview of everything that you've learned so far. Okay. Do you have the Ring Central in front of you? You're gonna need it. Because I'm gonna share it from here. Well, I don't know. Let me see.
It's getting worse. They hurt my nose so bad. I'm not gonna leave my eyes. Yeah.
I have a question for that thing that you just pulled up that we're gonna go over. Are you also gonna put that into Brightspace, or is that already in Brightspace?
The math.
Yep.
This math is not on Brightspace. This math is similar to all of the math that you have on Brightspace.
Okay.
But I am not going to do your worksheet for you.
Okay.
You know what I mean? Because I still
Yeah,
want
no,
you to have
that
a
makes
worksheet
sense.
that you can practice.
Okay, so there is a worksheet in there that we can practice on.
Yes.
Okay, perfect. Sorry, thank you.
Are you joining? Are we joining? Is everybody in? Yes? Yes, no? My people in the back? Are you on Ring Central? Yes? Okay. Well, that's because I didn't share it yet. Oh, where is my? Am I stupid? There it is. Okay. Okay, so please convert round to the nearest 10th place and only give, how do I make this go away? Go away. And only give the number, I can't see the whole freaking page, but you guys can read it. So we need to convert 2,500 grams to milligrams.
I don't know if it's just me, but I cannot see any of that.
Is it too small?
Yeah, it is so tiny.
Okay.
There we go.
Does that help?
That's a lot better. Thank you.
You're welcome. Okay. So, how do I convert grams to milligrams? Times it by 1,000. So, 2,500 grams times
Times it by
1,000
1,000.
equals what?
2,500,000.
So going from grams to milligrams.
Wouldn't you divide?
Divide, that's what I did.
Because you're going from bigger to smaller?
So how many milligrams is in 1 gram?
1 gram is 1,000 milligrams.
So 1,000 milligrams is equal to 1 gram. So you would need to multiply by 1,000. So if you did it this way, or
So wouldn't that
if
be
you were a person that likes
2,500,000?
to move your decimal point, you would move it 1, 2, 3, which would give you 2,500,000 milligrams. Okay. If I was going from milligrams to grams, I would divide by 1,000. Okay. Now remember, when you see this question, I told you this is exactly the same with different numbers. So do not forget a 0. Make sure you have all of your zeros when you put in your answer. Okay? I hate having to mark someone wrong because they forgot a 0. It kills a part of my soul. Okay? So when you're going from grams to milligrams, we are multiplying by 1,000. If you're going from milligrams to grams, we are dividing by 1,000. So our first answer is 2,500,000. Does everybody understand how we got there? Yep. Conversions suck.
Can I say how I remember
Okay,
that? Because it
so
took me
now
a
we
long time to
have-
remember that process. So the way I remembered it is it takes a lot
Go
of
ahead.
the little pieces to make the one big piece. I don't know if that'll help anybody.
Yeah, so she said it takes a lot of the little pieces to make one big piece, which is why we multiply by 1,000. Okay. So I have 175,000 micrograms to grams. So what just happened here? What comes between micrograms and grams? Milligrams. So we got to convert twice. Okay. So if milligram to gram is dividing by 1,000, microgram to gram would be dividing by what? You could do it twice.
1 million.
You could do it twice. Oh, 100% you could do it twice. Okay. So I love dimensional analysis.
I do too.
Okay. So I'm looking for grams. 1 gram is equal to what? 1,000. Oop, too many zeros, Jessica. Because you want to do it twice, right? So 1 gram is equal to 1,000 milligrams times 1 milligram is equal to 1,000 micrograms times 175,000 mics. And the reason I know I'm doing this right is because I have mics here, I have mics here, I have milligrams here, I have milligrams here, and all I'm left with is grams, which is what I'm looking for. Yes? So, could I divide by 1,000 twice? Yes. Could I do dimensional analysis where I'm also dividing by 1,000 twice? Yes. Okay. So what is my answer?
0.2 grams. If you're rounding up.
So, oh, it does say round to the nearest tenth. Oof. You should never round. I need to fix that. You should never round conversions. So, well, unless you're specifically asked to. Unless you're specifically asked to. But like there's one of these that it's like the answer is like 0.0023 or something. How do you round that to the nearest tenth?
Right.
When your 10th place is 0, your 100th place is 0, and your 1,000th place is 2. You know what I mean?
Well,
like that doesn't make any sense.
If not rounded, then it's 0.175.
Okay, can you
Right.
not just divide it by 2,000? Why is that different?
So you can't divide it by 2,000. You would have to divide it by 1. So 1,000 times 1,000 would be 1 million.
Right. Okay. Okay.
You
So
would have
it's a
to-
different.
So
okay.
in order to bypass the two conversions, you would have to divide by 1 million, right? You can't just divide by 2,000 because you have to convert it twice. You have to go from grams to milligrams and then milligrams to micrograms. Okay. So the easiest way to do
Thank
it
you.
would just be to divide twice, right? So 175,000 divided by 1,000 divided by 1,000 would be 0.175. Now, if I forget to remove the direction of, hopefully I don't forget, then, and we are rounding to the nearest tenth, the answer would be 0.2. Please pay attention to your directions. Okay. So now my next one is 3,000 milliliters to liters. So if I'm going to milliliters to liters, am I dividing or multiplying? Dividing.
Dividing.
So 3,000 divided by 1,000. 3 liters. Okay. All right. Number 2. Which of the following is the abbreviation for dextrose 5% in normal saline?
A.
B.
No.
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 It's
What is
B.
Oh,
W?
B.
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 W is water.
Oh my goodness, yeah.
So this is dextrose, 5% in water. This is dextrose, 5% in normal saline. This is normal saline. This is dextrose, 5%
normal saline.
in what? 0.45% saline. Half saline is not 0.5. Fall for that, please. Half of 0.9% is 0.45. So half strength saline is 0.45%. Please don't make that mistake. Okay? Okay. So we see the difference in what this means, yes? So what is my answer? B. That would be 0.5% saline. Yeah, 0.45. All right, so a nurse is preparing to administer magnesium gluconate, 250 milligrams PO. Available is 100 milligram tablets. How many ml? What?
Yeah.
Who made this?
That one doesn't work.
Okay,
Shouldn't it be how many tablets given? Because mLs ain't nowhere inside.
we're gonna, this is tablets. Okay, so I'm gonna make a note. Jessica needs to check the exam. Check the exam. So this is gonna be tablets. Okay, so you have your order is 250 milligrams PO. Available is 100 milligram tablets. Okay. So I'm looking for tabs. I have 1 tab equals 100 milligrams times my order of 250 milligrams. Okay. Which is going to give me 250 over 100, which equals 2.5 tablets. Do we need to write tablets? No, we do not. Just 2.5. Okay. Everybody good on that one? Yes?
Yes.
Yes. Okay. A nurse is preparing to administer normal saline, 1200 ml IV to infuse over 6 hours. What is the rate in milliliters per hour? Okay. So if I have milliliters per hour, that's what I'm looking for. I have 1,200 mLs over 6 hours. That's it. There's no more fluff. There's no more numbers, right? So what is 1,200 divided by 6? 200 milliliters per hour.
200.
Okay. What? What? Can't see my comments. Okay, so how, and I'm not trying to call you out. I just need, I want everybody to be on the same page. How did you get 0.005? I mixed up my numbers. Okay, but do you see how you mixed it up? Okay, perfect. That's what matters to me the most. Listen, This is not about feeling stupid. I need you guys to please, please understand that. Okay. This is about learning together. And there are no stupid questions, because I'm telling you right now, somebody next to you or in this online is screwing it up too. Okay. You're never going to be the only one. All right. So please don't worry about that. This is all about us learning together and being successful. All right. Oh, it's 2:35. If you need to leave, if you need to jump off, you can. Okay.
Thank you so much, Jess.
You're welcome.
Yes, thank you and have a great day.
If it was 7 hours. Oh, we'll get to drops. Don't you worry. Yeah, if you guys need to jump off, you can. This is going to be posted. So please, if you do have to jump off or leave, please, please, please make sure you look over this before Thursday. Promise me. Okay. So a nurse is preparing to administer vancomycin 1 gram. Available is vancomycin 500 milligrams per milliliter. How many ml should the nurse administer? Okay. So I'm looking for mLs. I have 1 ml is equal to 500 milligrams times, do you want to convert in the problem? Because we have to convert grams to milligrams. Or do we realize that 1 gram is equal to 1,000 milligrams? You have to see it? Okay, that's fine. That's fine. So times 1 milligram is equal to, 1,000 times 1 gram, right? No, that's wrong. That's wrong. That's wrong. Because I have to be able to divide. So 1 ml is equal to 500 milligrams times.
Wouldn't you just convert the grams to 1,000 and then divide it by 500, or no? Because it gives 2.
It's gonna be 2.
There we go. Because this needs to match. So I have grams here, I have grams here, I have milligrams here, and what I'm left with is mLs over ml, or ml and ml. So when you are doing dimensional analysis correctly, you should be able to cross out your matches. So when I say a match, this is a match to this. This is a match to this. Okay? So what I'm left with is the only thing that I can't cross out. I don't have mLs anywhere else because that's what I'm looking for in the end. Does that make sense? Okay. So in the end, I'm left with 1,000 over 500, which is how I knew I was wrong the first way, because I knew I had to divide. Okay.
Can you teach a desired over half?
It is across the board in every nursing school in the country that dimensional analysis is the gold standard and is what should be taught.
Yeah, but I already learned this, a couple of years ago at a different nursing school, and it confuses me to have to try to learn it a different way.
I totally get that. I've had a lot of issues with students that are in those same shoes. And when you feel that way,
yeah.
Now what I can say is that I really, truly would love for you to try. If it is going to cause you to fail by learning a new way, I don't want you to do it because I don't want you to fail. But at the same time, I can't teach you desired over have or formula because I was never taught that. I only teach dimensional analysis and that's the only one that we teach, that we should teach here. It does have all three on the modules. Okay. But it is very important, hopefully, that we can come to terms with dimensional analysis. Okay. So 1,000 divided by 500 is what? So the
2.
answer is 2 mLs. Okay. All right. So a client weighs 70 pounds, 8 ounces. What is the child's weight in kilograms?
32.
So first we need to convert our ounces. You have to convert your ounces first. Okay. So how many ounces is in a kilogram? Or I'm sorry, is in a
16.
pound?
16 divided 8 divided by 16.
So we have 8 ounces, which would give us 8/16. And that's going to give us 1/2, which is 0.5. Okay. So then 70 divided by 2.2 is what? Oh, I'm sorry. 70, yeah, 70.5. Sorry, my bad. By 2.2.
32.04545, continuing. So we round it to 32.
So it's 32.04545545, blah, blah, blah. But we need to round to the nearest tenth. So what is my answer? What?
32.
No, to the 10th, my nearest 10th. My answer is 32. Okay. See, this is why we practice. Okay. So our next one is drops per minute. Okay. And it says we need to round to the whole number. Okay. We can set a pump to deliver 75.4 milliliters per hour. Even in critical care, you can go to the hundredths place. A standard pump, you can only go to the tenths. But when we're talking about drip rates, drops per minute, you cannot cut a drop in half. So a drop always has to be a whole number. Okay. So we are looking for drops per minute. So we have 20 drops per 1 ml times 720 mLs over 6 hours times 1 hour is equal to 60 minutes. So how do I double check myself? I have hour here and hour here. I have mLs here and mLs here. And what I've left with is drops over minutes. Okay. So 20 times 720 is 14,400. And 6 times 60 is 360. So now you have to multiply across. So 20 times 720 is 14,500. And then 6 times 60, because we're multiplying across, is 360. So 14,400 divided by 360 equals 40 drops per minute. That's why it's so important to double check your dimensional analysis. You have to be able to cross out. You have to be able to match what's on the bottom to what's on top. So you see how I'm crossing them out? I have to be, if I have milligrams on the bottom, I have to have milligrams on the top.
So like this.
Well,
I've had students where literally when we do math together, they literally shut me out.
Yeah.
Like, I'm not kidding. My girl Lisa, who's about to graduate, when I do math, she's like, I'm leaving. Because she has been doing her way of math for 2 years. And she's like, I know how to do it. I'm getting it right. I cannot do this. And I'm going to respect it. If you can do it correctly and you get the right answer, I am going to respect your process.
Yeah, 'cause
It's just, all that matters is that we get the right answer. So as long as you can get the right answer with the way that you're doing it, I'm okay. But if you want to learn dimensional analysis, that's okay too. Okay. All right. We only have a couple left. So a nurse is preparing to administer methylprednisolone. The prescribed dose is 175 milligrams IV every 12 hours. Your supply is shown. How many mLs should the nurse administer per dose? So it says here that I have 500 milligrams per 10 mLs. So I'm looking for mLs. I have 10 milliliters per 500 milligrams. And my dose is 175 milligrams. So times 175 milligrams. And that's it, because I don't need to go any further. The every 12 hours is fluff. I don't need to include that. That's just telling me that it's twice a day. Okay. So 10 times 175 would be 1,750 divided by 500 is what? .5 mLs. Okay, did you get that? How are we all doing? We only got 2 more. And the last one's easy. So a nurse is preparing to administer cefazolin to a child who weighs 36 pounds, 4 ounces. The medication reference recommends 25 milligrams per kilogram every 8 hours. How many milligrams per dose should the nurse administer? So what I would do is it's every 8 hours, which means it's 3 doses a day, right? So I need to figure out, first of all, I need to convert my pounds to kilograms. That's the first thing I need to do. So, and I have ounces. So I have 4 ounces and there's 16 ounces in a pound. So break that down for, what is that, 1/4? Which is 0.25, okay? By the way, you never round weight in the middle of a question. So I would never round this to 0.3 in the middle of my question. You only round at the end, okay? Never round weight in the middle of a question, all right? So then that gives me 36.25 pounds divided by 2.2. Which gives me, now this is where you can get tripped up, because it's giving me 16.477272727. If I round this to 16.5, it's going to change my answer. Okay? So I'm going to keep my number on my calculator right here. All right? And I know it says it's 25 milligrams per kilogram. I have my kilograms on my calculator. So I'm going to multiply this by 25. Okay? This is per day because the medication reference recommends 25 milligrams per kilogram.
Okay, I'm confused because it doesn't say slash per day like it said. In the
Like it should.
before.
I know.
Okay,
I don't like this question.
yeah.
Oh, so it does say per dose. Because this isn't per day. Because that's a good catch. That's a good catch. So this says the medication reference recommends 25 milligrams per kilogram every 8 hours. So that means that's the recommended dose per dose, not per day. Okay? So I have, when I just did that multiplication, 411.9318. Okay, blah, 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 continued. Now I round to the nearest tenth. So are you following or did I lose everybody right there? Are we following or no? Okay. Do I have anybody left online or did they
I'm
all
still
leave?
here.
Oh, no, they're here. How are you doing online? Are you following me?
Yeah.
Yes.
Okay. So this gave me 36.25 divided by 2.2 gave me 411.93181818. Now I need to round to my nearest tenth. So what is my answer? 412. Actually, no. It would be 411.9. You lost me with the 412. I was like, yes, you're right.
Wouldn't you round that up to
No.
12 though? Because 9 rounds up to a whole number?
Well, if we're rounding to the nearest tenth, it all depends
Okay.
on this number. 3 is less than 5. If it was 411.95 or 96, then the
Okay,
answer would be
I understand.
412. Okay. And then the last question is easy. The nurse is preparing to administer insulin glargine 150 units sub-Q. Which syringe should the nurse select for this dose? Can you fit 150 units in a 100-unit syringe? No. This person has very bad diabetes. Okay. You could get a 100 and a 50, but I don't want to stab you twice. So I'm going to do B.
500.
So remember, the worksheet, the math worksheet is a prerequisite. The what? What? The math worksheet is in Brightspace under week 1. The math worksheet must be done. It is a prerequisite to your math exam. You will not be allowed to take your math exam unless the math worksheet is done. Okay? Goodbye. I hope you had a wonderful day.
Hey, Jessica, there was no
Okay.
worksheet, but there was a quiz
Yes,
and I
ma'am.
did that. There was no worksheet, but there was a quiz. Is that what you're talking about?
No, math week 1 all the way down. under math, it says RN 2210 math worksheet. Oh, it does, it technically it's in quiz format, but it's called math worksheet. But it's in a quiz format on Brightspace. That's why it's under quiz. Does anybody have any questions before we log off?
I
Are
have
you good?
one. Sorry, I know you have a lot going on.
Thank you so much.
You're
My
welcome.
thing is that I emailed you about it, but my ATI doesn't have any of my pharmacology stuff.
If it's anything with ATI, I need you to email Christy.
Dr. Bowling. Okay,
Dr.
I
Bowling.
will. She said it would all be available, but I'm.
Yeah. kbowling at
Oh, you know I got her
rosseducation.edu.
email. You know I got her email.
Yeah. Anybody else have any other questions? Good? Okay, I'll see you on Thursday.